Thank you. We're waiting for a couple more people to come in. All right. So we do have quite a full agenda for today. Just going to do a little bit housekeeping and introduction. I see some new faces. We're going to quickly go over the purpose and guiding principle and the role of a subject matter expert. Also, we use the SME acronym. We'll also go through the enterprise overview. Our acronym is EO. We will do an EO demo where we walk through the clinic overview. We'll talk about the referral and triage process, the scheduling, health, HIM, and a day of visit. And we'll also do demo by myself and Hilda as well. And we'll also compare and contrast the current enterprise overview and how that marries with your current workflow. We'll talk about the clinician documentation, the different ways that you can document within Cerner, such as using auto text in dynamic documents, using iView, more of a ticky box, PowerForm, which is a electronic version of your forms, and then FormFast, which is anything that you need a wet signature from. You can print it off from FormFast. We'll go over some forms in high level just to clarify some questions we have. And we'll ask the clinic some questions, and we'll also give the clinic an opportunity to ask questions for us. And then we'll talk about the next steps. Before I go into housekeeping, do we have any urgent questions, or not sure why we're here today? Okay, thank you. For housekeeping, just so that we can hear everyone, please mute yourself when you're not speaking. And because I'm just meeting you all for the very first time or just starting to meet you, please state your names so that we can also support meeting notes and follow action items. And so I get to know you as well. And if you have any non-urgent questions, feel free to, I know usually we say pop it in the chat, but for myself, I have no problem if you just put up your hand or unmute yourself and ask. I find that's more organic, and we can have a more robust conversation that way. All right, do a quick introduction with the team. If you can just say your name and your areas of expertise, that will be great. We'll start with the clinic side. So we'll go down the list. If you're not here, I will go to the next person, and anyone that's not on this list, please feel free to introduce yourself as well, so we'll get to know you. Right. I do not believe Baljit is here at the moment. Is there someone here on Baljit as a delegate, or?
Yeah, hi, it's Jonathan Chung. I'm here on Bal's behalf. He's on for vacation today.
Thank you. Nice meeting you, John. Dr. Sampat?
My name is Dr. Sampath. I'm a surgeon. Sorry, did you ask for me? My kids are yelling in the background. Anyways, I'm a surgeon. I'm the director of the Metabolic and Bariatric Surgery Program at Richmond Hospital.
Thank you. Okay, do we have Dr. Hintz here? Let's see. Okay, and Dr. Ringbold? Dr. Ringbold, can you hear me? Are you still on mute? We might need to come back to you. Sorry, we can't hear you. And then Dr. Chang.
Oh, hi, Dr. Chang. I'm a family physician. I'm a bariatrician, helps out with the program.
Hi, this is Siri. Sorry, you guys, I couldn't figure out how to unmute myself.
Nice to meet you. And Dr. Ringbold, you're the psychiatrist at the clinic.
Yeah, I'm the psychiatrist.
Thank you. Do we have Dr. Harris? Dr. Ahmad?
Yes, I'm Iqbal Ahmed. I'm a respirologist, and I deal with the sleep apnea, particularly in patients.
Thank you. I see Dr. Nguyen here.
Hello, yes, I'm one of the surgeons.
And now,
Hi, yes, morning. I'm the unit clerk with the program.
Raj.
Yeah, I'm one of the nurses with the program and also the team lead.
Thank you. Anyone else from the clinic that I have not had the opportunity to speak with?
I think Nushin is here as well, one of our dietitians.
Hi, I'm Nushin Alizadeh Pastor, the dietitian. Nice to meet you.
Introduction. And anyone else from the clinic?
Our mental health clinician, Manpreet, will be joining us in about 10 minutes.
Great. All right. I'll let the clinical informatics, the rest of my colleagues introduce themselves, and then we'll go over the CST team here. As you can see, there is a huge team that supports this this process here. And for the CST team, there is a person dedicated to each specific area of Cerner. So you can see who is involved with that design area. If you have any questions, these are the experts that help us with that area of Cerner. So over to you, Hilda. I'll let you introduce yourself.
Hi, everyone. My name is Hilda. I'm one of the clinical informatics manager who will be working on this clinic together with Mary and also Gabby as well. Nice to meet everyone.
Hey, Gabby, would you like to go?
Yep, good morning. My name is Gabriella, and I am the clinical informatics specialist who will be supporting Mary, Hilda, and the rest of the CST team.
Great. All right. Kristen, would you like to go next?
Hi, my name is Kirsten. I'm on the ambulatory team. I'm a project manager, and our BA is Dolores Cuzel, who's away this week, as well as Eric Chan, who's on the line. And I'm supporting just on more of project side, but with some notes during this meeting as Dolores is away.
Great, thank you. Scheduling team?
Hi, my name is Heather Eli, and I'll be responsible for the scheduling build of this clinic.
Hi, my name is Prabjot Chahal. I'm the scheduling team business analyst.
Thank you. And the registration team?
I don't see Jocelyn that I am Maria Clara Avila. I am one of the BA from registration, standard, and data quality.
Thank you. And lab?
Good morning. My name is Rana. I'm a clinical informatics specialist supporting the lab.
Thank you. Order set team? I'm going to go over to medication management. And the provider experience and adoption team.
Hello, my name is Sophia Gu, and I am system analyst from provider experience.
Hi, I'm Elena Marzello. I'm with provider adoption, and I see our director, Johanna Benelia, here as well.
Yeah, good morning, Johanna Benelia. I'm a surgeon by background, and I am the director for provider adoption and experience.
Thank you. I believe we also have professional practice team here.
Hi, good morning. My name is Kate McNamee. I'm the Director for Professional Practice, Nursing and Allied Health at Richmond.
And hi, everyone. I'm Vina, one of the nursing practice leads supporting Richmond as well. Thanks for having us.
Thank you. Anyone that I have not called upon to introduce yourself?
Mary, I think Dr. Hintz just joined our meeting as well.
Perfect. Welcome, Dr. Hintz. We're just doing a quick introduction. So we've gone through the clinic and also the CST team. The team members here are responsible for a specific area of Cerner. They're the experts, shall we say, in those areas. So we have the scheduling team, registration team, lab team, etc. And my name is Mary, and I'm the clinical informatics working along with Hilda and Gabby to help bring the metabolic bariatric surgery clinic over to Cerner. Would you like to give a brief introduction? I'm sorry, if you're speaking, Dr. Hopkins, I cannot hear you. Can you hear us okay? If you can hear, hear me, can you give me a thumbs up or a message in the chat? Just want to check. The reason, when we introduce each other, it's a good way to do a sound check and just make sure we know where the mute button is. Like a warm-up exercise. Okay. We'll just type a message here. Okay, so I'll give you a moment to respond, but I'll continue on with the presentation. So why are we here today? Today we are here for the design session where we'll review and confirm the Cerner built option, and that will be used to meet the clinic's identified requirements. By requirements, we mean workflow, resources, needs, things like that. So we'll plan to review the workflow and validate what works and identify any key gaps between the enterprise work and the clinic workflow. So by doing so, we'll need to review the contents and the current that currently exists in Cerner, and then we'll validate and what contents work as it is identify any key gaps or changes that's required in order to kind of overlay or transpose over the clinic's workflow. In addition to this design session, upcoming, there will be scheduling specific sessions with the scheduling team. And we'll ask for the SMEs that will come along, for example, clerk. And then they will talk about requirements gathering. We'll also have a design sessions like what we're doing right now and a validation session, which is kind of an opportunity for the clinic to see what we have built for the clinic. And you give us the stamp of approval if that is what's working, or you let us know if it's something that can be changed for you. Also, there would be an order set specific session. So this series of sessions is dedicated with specific SMEs, for example, providers, to go through the same ceremony requirements gathering. That's where we take down the information, the workflow, then we bring it home and we massage it and see what we have in Cerner, or if we need to build something for your clinic to work. And then we offer what we've built or what we have during the validation session. And then again, you give us the stamp of approval if we get thumbs up from you, if it works for your clinic, or you let us know that's something we need to improve or work on. People set up their audio there as they join us. So guiding principle for changes with Cerner. Guiding principle. So with Cerner, because it's used across various health authorities at different hospitals, we try to keep it as one size fits all as possible, and recognizing that that may not be possible all the time because every clinic is very unique. But the reason why we try to keep it as one size fits all is because of the maintenance costs and the amount of resource that needs to do upkeep and sustainability. So going over guiding principle number one is no change for the sake of change. So when we do change, we consider safety, change that have patient safety implication, regulatory changes that are required to meet regulatory or reporting requirements and national/international standards. We'll make changes if it's due to financial changes that would create efficiencies without requiring significant operational cost implication, or We'll do changes requiring content change to add content that currently does not exist and is required for the clinic to run safely. Another guiding principle is our focus to enterprise design. As I alluded earlier, there is a lot of sustainability and upkeeping resource that's required. There's many versions of Cerner. So we are converting the enterprise-wide, meaning all 3 health authorities. We will prioritize our design topic based on what is needed first to go live at each site chronologically. And then post go live, there's something called the sustainment period, where we can do nice to have or any upgrades that's needed for the clinic. Other design topics will follow a specific schedule as to when these will be accomplished in alignment with the go live roadmap. And guiding principle number 3, our priority is must have. So these are the must have in order for the clinic to go live safely and assist with the patients and be able to facilitate their workflow. And then the nice to have is something that we can add post go live. I'm going to stop here and just ask the floor if anyone has any questions. Any questions regarding to the principle, the guiding principle of changes with Cerner, why we're here today, and the ask from the subject matter experts? Okay, I hear none. So I'm going to dive into the clinic workflow and the patient journey. So for this clinic, we have chosen the multidisciplinary clinic end-to-end workflow in terms of the enterprise perspective. This is the patient journey that we have for our enterprise design. And we want to have this kind of overlap and see overlap with the clinic's workflow and see if there's any gaps we're missing. And this is why we have this design sessions today. So with the patient journey, first, the referring provider will send off a referral to the clinic. And this is the high level. And then with the referral, they'll come through the clinic and go through a screening and triage and wait list. Then they will go through the wait list. And when it's time, they'll go through an orientation preparation. And in order for them to go to the preparation, they'll schedule the appointment, we'll confirm the appointment with the patients. And during the orientation, we'll check in and register the patient. After the orientation, the patient's given the signed contract, the participation contract. And once this is received, it's sent back to the clinic. And then after that, the clinic will then book an appointment with the patients, with the nurse to do the initial assessment and documentation. And then step 4 to 12 is a repeat process depending on how many sessions they need to meet subsequent sessions with the nurse or the registered dietitian along their journey before they are a surgical candidate. So step 10 and 11, these boxes are in gray. We heard that this clinic does not do any medication administration or perform any procedures and treatments in the clinic. So we just want to confirm that. Is that correct? Is our understanding correct?
Yes, that's correct.
And with the clinic, it's our understanding that after the surgery, the bariatric surgery, the nurse will go out to see the patient on post-op day 1, do discharge teaching. And after that, there will be a follow-up session with they'll follow the patient for 2 years. And after that, when it's deemed safe to do so, the clinic will discharge the patient. So that's our high-level overview of the clinic's workflow. Is there anything I've missed? All right. But we're gonna go over what Cerner or how Cerner can accommodate the clinic's workflow. We're going to do it in chunks. So we're going to separate the receive referral, the screening and triage waitlist, the orientation, which will be done out of system, but we'll talk about it. Then we'll see the clerk schedule the appointment, and we'll see the clerk confirm the appointment with the patients. Before we dive into Cerner and walk through this process, does anyone have any questions, comments, or concerns? So I'm going to stop my presentation mode and bring up Cerner. Let's see, this is the notes. Okay. So the step one, receive referral, that will be from the referring provider. So I would be logged in as a provider. Normally you would not have this many Cerners opened up, but for the purpose of demonstration, I have two. I have general medicine surgeon, general med provider login. And so this is what you see when you log into Cerner. This is the message center on the left, and this is the messages. Come back home here. The home button at the top. So when you're at the home page, you can see your message center on the left and the ambulatory organizer. Ambulatory organizer, it's kind of like your day book for the clinic. I won't dive too deep here because I know we are quite pinched for it. We have a jam-packed schedule, so I'm going to look up the patient that I want to send a referral to the clinic here. Okay. So what I'm doing now is what we call a internal referral. And in Cerner, when we say an internal referral, it means that I am referring a patient using a Cerner site who is going to another Cerner site. So for example, VGH has been live since November of last year. If a provider from VGH would like to refer a patient to St. Paul Hospital's clinic, that's what we call an internal referral. Any questions about that? So for the referral here, we don't have the clinic built into Cerner or your clinic built into Cerner at this point of the project. So for our normally the project will use a comparable clinic. Since this is a new build, the closest clinic that we have would be the VGH Gender Surgery Clinic. So you will see me put down referral to VGH Gender Surgery Clinic.
Can I make a comment?
Yes.
We don't have any internal referrals. Can we just go to external referral?
Okay, can you elaborate what you mean you don't have any internal referrals?
All the referrals come from GPs in the community. So there's no such thing as an internal referral.
I see. Okay. Hilda, should we then move past this, or do you have any comments, Hilda?
Yeah, no, thank you, Dr. Nguyen, for providing that information. So knowing that there is no internal referrals, meaning that you guys will not get any referrals within Richmond, VGH, St. Paul's, and any of the live sites. Can I just get that confirmation?
May I add something? Thanks, Dr. Nguyen, Mary, and Hilda. We don't have the patient referral from the outside organization to the clinic in that way, but let's say as a dietitian, I want to refer the patient to Dr. Capulut or Dr. Harris, for example. That we have that kind of referral. I don't know, will be considered as this stage of the work or another part?
Yeah, Nushin, that is very good question. So for what you have mentioned, for instance, for a dietitian to be referring the patient to the endocrinologist or a respirologist or another specialty, and those are more like out into their private office, and those will be what we consider as external referrals. That was like will be following current state, meaning that you're just going to be referring these patients to see the specialists at their private office. Is that what you're referring to?
Yes, yeah.
Yeah, so we will go through that as the number 12 step, which is the follow-up slash like kind of like referring to a specialist at the end. So we will definitely do kind of go through that workflow at the end of our at the last step of our demo as well.
Yeah, may I ask one more question? Sorry, this is my first time attending this meeting, and maybe this question is being answered or will be answered later on. I'm just curious because I understand that surgeons and physicians, they have their own system, for example. Some are using PCIS, some are other system. So I'm just curious how it's going to, Cerner will be working with those systems, because I'm sure no one wants to chart in two places.
Absolutely. Yeah. So we'll definitely go into more detail to talk about that process at the end with the follow-up or the patient departure step. So you mentioned a very good point, and that's one of the discussion that we're hoping to have with the group today, is talk about like, you know, the different EMRs that are being used within the different specialties with the private offices, and also how that would look like with Cerner coming into your clinic. So we'll definitely go into more detail at the end.
I appreciate it. Thank you.
Just a quick comment. So like Dr. Nguyen mentioned, the majority of our referrals come from GPs or other primary care providers in the community. However, you know, there are a few referrals, the one-offs that come to us from patients that are maybe hospitalized at a certain hospital, and a doctor might reach out to us or want to know how to go about the referral. So as long as that process is built in, that would be great.
Okay, Raj, thank you so much for that. And that's what I'm trying to confirm as well. So if you do get what we call internal referrals, meaning that these are referrals coming from Cerner hospitals like VGH, Richmond, Lionsgate, and St. Paul's, and that's what that internal referral order will look like. I think Mary was also trying to place that order. So do you still want us to go through that process? Knowing that it's rare, but it does happen.
Maybe just very briefly. I think some of the surgeons are probably have a crunch for time, and because the external referrals are mostly what we see, we could spend more time on that. That would be great.
Perfect. So we'll go through just the steps, and then we'll jump into the external referrals.
And just a comment, a lot of the clinicians have to start their clinical day, whether it's surgery or office, very soon. So can we just go to the steps that involve us, particularly, you know, the interface with the outside EMRs first?
Okay. Thank you, Dr. Nguyen. In that case, we can definitely go back into the internal steps later on, and then maybe I'll just go over the external process or the workflow, referral workflow, so that way so for the time there'll be better use. Okay.
Great. Thank you for that conversation piece. So I'll just adapt the presentation according to what was mentioned. So I'm going to go back to more of the slide deck than the Cerner. So as I mentioned earlier, there are two types of referral. When we do an external referral, so from the community, these referral will come through a fax program called a work queue monitor, also shortened to WQM. From there, the clerk will create an encounter, and any fax that comes through can be indexed into the patient's chart electronically. And to quickly summarize, internal referrals coming from a Cerner site come through a program called Scheduling Appointment Book or Sketch App Book. And then the same steps, clerk will create an encounter and put in, and then you don't need to index anything because it'll automatically be in Cerner because it's a Cerner site referral. But if needed, the clerk can also index, if anything comes through a fax, the clerk can also index it to a patient that was an internal referral. All right, just gonna get a gauge. So okay if I continue with the slide deck and then go through the demo and then focus more on the external part first? Some nods. Okay. Receiving referrals. Just want to ask the clinic here. So from what we've seen on the survey and through our enterprise or requirements gathering sessions, we heard there are urgent referrals by the medical weight management program. We just want to understand where are these medical weight management program and can the clinic provide a list of these clinics and with special authorities to send quote unquote urgent referrals to the clinic?
Yes, I can provide a list of them, but this will probably grow as time goes on as well.
Do you know, and sorry to put you on the spot, do you know the percentage of breakdown of how many are from the medical weight management program and how many referrals are from the community?
I'd say probably at least 35% are from the medical weight management centers.
Thank you. And along that line, are there any other source of referrals that require urgent referral status, such as patient that requires weight loss surgery prior to their main? Yes.
Yeah, sometimes there's patients where specialists like nephrologists maybe are referring them because they need an urgent kidney transplant, for example. That would be an urgent referral as well.
Great. And those are the rare internal referral you were mentioning earlier. Is that correct, Raj?
That would be one example. We've had a case in the past too where a patient was hospitalized for another reason, and it just so happened that obesity was lending to a lot of illness, and that patient was then referred to us as well.
Okay. And any other source of referral status that we have not touched on?
May I add, the occasion get referral by surgeons. They want the patient, might be our patient or patients that have come for severe complications from doing surgery in medical tourism, come to see dietitians. So we see we get those urgent referrals too, but that's not that common, very rare.
Thank you. Just gonna pause. Does my colleague have any questions? Any follow-up questions?
Mary, knowing that the surgeons are going to be leaving soon for to attend to patients, do you want to maybe go through the external referral demo first, and then we can come back to the questions?
Yes. So Hilda, I will let you take over for screen share, and I will jump into.
Hi, sorry, it's John here for Richmond Surgery Project Manager. I would encourage, aside from the demo, just to really focus on some questions that you might have for the clinicians and the physicians, because they will be starting the day soon. It might be hard to grab time later.
Thank you so much, John, for that. Yeah, so we'll go through the external referral process a little bit, and then that way we can kind of start asking for the questions as well. All right, so I'm going to be acting as a clerk for the demo today. So what I'm showing here is the what we call the work queue monitor. So it's the kind of the digital fax machine. So what happens is that any faxes that will be coming into your clinic in the future will be digitally scanned into the work queue monitor. And this is how your clerk will be accessing all your external referrals. So today I'm just going to be using this, what we call the unknown queue. In the future, a queue will be created for your clinic. So you'll have all the faxes that are directed into your own clinic queue. So I have faxed or created kind of like a demo referral using your clinic's referral package with the patient's information. So this is what your referring provider will be filling out. So this is the fax that comes through with the date and time that is time stamped. So now I'm going to attach this into the patient's chart and then push this patient over for triage. So as the clerk, I'll be able to kind of look through all the information that is on my on the referral form. So now I'm gonna look for the patient to see if this patient is in the system. So I can see that for this patient, there is what we call an emergency encounter, meaning that this patient has visited the VGH Emerge previously. But for my purposes, I need to create an encounter for my clinic. So I'm going to add an encounter. And for a demo today, as Mary has mentioned, we're going to be using the VGH Gender Surgery program as our demo.
And the loading time is just a training domain.
Mary, so yeah, so right now I'm in the kind of the train domain, so it's not the live domain. So normally it doesn't ask for search for the EMPI or the external EMPI system twice. So here there are some basic information I need to put in. I'm just going to quickly put that through. And this is all listed in the referral form. So one thing that I'm gonna very quickly. So any of the yellow field that you see here are what we call the required fields, meaning that I cannot proceed with completing the creation of encounter without filling out all the required fields. So let's see, for surgery and the referring provider. So one thing I do wanted to point out, so the referring date is like when we receive the referral, so that is on the work queue. So I received this referral yesterday and the referral status. So for me to push through for the triaging of this, for this patient, I'm gonna put this patient that is ready for triage. And I know that for your clinic, you do have urgent referrals that are coming from the medical weight management program. So this is what we call the triaging priority. So the clinic can set different priority for their referrals. So for instance, if the patient's referral is coming from the hospital, they might, or from BD, they might have a higher priority than external or community referrals from the GP. So each clinic can decide whether they have different categories for their priority for their triaging. So for instance, if urgent referrals are always for the weight management program, so you can prioritize them as like a 1 or a 3 based on priority that is set by the by your clinic. So as long as there's internally a standard or a guideline for the clerk to know that which referral equates to which priority, the clerk can kind of like start assigning priorities for these for these referrals, and that will be easier for the triaging nurse or provider to be going through these referrals. So I'm going to set this priority as 1 right now, and we're going to show you what that would look like on the triaging side of things. Okay. And once I have set complete, it's going to ask me whether I want to print any armband labels or face sheet. We usually don't print this at this stage, so I'm going to say no. Okay, and now I'm going to so a referral encounter has been added on this patient, and now I'm going to attach this referral package onto the patient's chart, and you'll be able to see what that would look like on the patient's chart later on. Sorry, one more thing. So this is a referral package. So you can see earlier, the system won't let me proceed unless all the required field has been populated, and will give me a pop-up if I miss any steps. So now I have completed all that. Letting me, oh, that's what it is. Sorry, I have double monitor, so it's popping up on the other side. So I need to select the referral package. And as you can see now, the fax that was coming in from yesterday, it's no longer on my queue anymore. So the clerk will just kind of go through each of the individual queue and attach each of the individual referral packages or faxes onto the patient's chart. And I'm gonna pass over to Mary, who can show you what that package will look like on the patient's chart, and then how to do triaging. Before we proceed, any questions about this process?
Great, thank you. So now I am logged into what we call a referral management application. As you can see here, that we update the location to BGH Gender Surgery Program. You do this once, set it and forget it. Referral status will be on ready for triage medical service. The moment you don't have to select it. We're still designing the medical service for this clinic here, or determining. And then everything, we can leave it as open as possible because by these two, it's quite specific already. Then we do a run. And as you can see, when we run the report, we see the patient here. Okay, so we click. And then we have this pop-up box. If it's your first time accessing the patient for the day, I'll ask you to assign a relationship with the patient. That's basically to state I am charting, or I am reviewing this chart because of ABC reason, and because I'm the nurse, or I'm the covering provider, or the consulting provider. You will have that option according to your discipline. When we go through the patient's, what we call the workflow page, let's see. Can add these tabs here. These are kind of like, you can think like a quick tab that will amalgamate a lot of information to have on hand to make a very specific workflow fluid. So in this case, when I'm triaging, I want to look for a referral triage tab. So Cerner will quickly grab stuff that you would need to help you with your triage process. In this here, we see in the document section, here we are, we see the referral package. And I can click on it and press the view documents. And the system will automatically populate the referral documents that was faxed and that the clerk has indexed. Go through the different pages. If the patient has been to other Cerner site, you can also go through their notes or their documentation. Just a tidbit here. The notes do cross encounter, which means if they've been to Mount St. Joseph, St. Paul's, VGH, you will see that accumulated in this section. And you can always do a fill.
Sorry, Mary. Sorry to interrupt here. I recognize that I think there's a want and desire to show the entire flow, but I just want to ask if there are any, if we can move up the physician portion. I understand there might be an interruption to your process. Yeah, I'm just mindful of the time. Thank you.
Okay, thank you for the heads up.
Mary, I might just support that by saying, if you can break this down into questions that you have specifically for the physicians, because we really don't have to get moving on with the day. That would be super fantastic.
Yes, we can do that on the fly. Just bear with me for a moment. I need to kind of filter the question as I go through the slides, so I apologize if I sound a bit stop-go. Right.
So maybe we can just kind of have some general questions here. I think one of the biggest things that we wanted to know is that for the patient that are being accepted into the program, there's usually some kind of like standard blood work or standard diagnostic testings that are usually being ordered for all the patients here. I think one of the questions that we weren't quite sure is how is these orders being placed, and then who is responsible for reviewing these orders, current state?
Yeah, that's a good question, Hilda, because a lot of these tests, including blood work and ultrasound, et cetera, are ordered in advance of the clinician seeing the patient, just to facilitate flow. And so we have to be a bit careful about this, or else, we end up with a lab work that is ordered under my name or some other provider's name, and I'm not responsible for the patient. So I'll let Raj talk to that, but that is of critical importance.
Yeah, so Dr. Sampath's right. Typically what happens is there are standard tests that every single one of the patients will need basically very soon after doing their orientation and opting in, and just standard tests are blood work and abdominal ultrasound, the bone mineral density test, and some sleep apnea screening. And so typically what happens is these orders or requisitions have already been stamped with the appropriate provider's name and MSP number, and we start organizing these tests. That would be the unit clerk that would start organizing these tests very soon after the patient joins our program. So I think that's what Dr. Sampath means in terms of if we're now having to rely on a doctor ordering these, A, none of the doctors have yet met the patient, and B, it would interrupt the flow.
Absolutely. So I think my next question is that, so Raj, you mentioned that these kind of like are standards that all the patients would get. Is there like a difference on, because of the patient's medical history, there are certain tests that are only, for instance, like for sleep apnea, they might have like a history of like, sleep apnea or obesity and things like that, that you would order only for specific type of patients. Is there like specific guideline or protocol currently, or decision support tools or DSTs that are currently guiding you to say which patient would require which?
So for the sleep apnea, for the blood work, the bone mineral density and the ultrasound, no. Every patient has it done unless they had an ultrasound done in the last year or a BMD done in the last 3 years. Otherwise, every single patient has that done. Same goes for blood work. Sleep apnea, yes, there is a screening form for it. It's through the Ministry of Health, and it's a specific HSAT form. And patients have to meet certain criteria. You have to answer yes to 2 or more questions in order for the patient to have that test. And so that's the only test where if the patient doesn't meet criteria, we refer on to Dr. Ahmed, our respirologist, so that he can do an assessment and then take it from there.
Raj, the other test is the 24-hour urine for patients who have a history of kidney stones.
Yes, you're right.
And then after they've been seen by the clinician, we may order other tests, gastrographin studies, pH manometry, etc. But that doesn't happen until we become involved. So probably we can.
Those you would order from your private clinic then, right, Dr. Sampath?
Correct.
Okay, sounds good. So it sounds like there are some standard tests and blood work that are being routinely ordered for all the patients that are being enrolled into the program. And current state, Raji mentioned that there are some stamped requisitions that are being sent out. So in future state, I do want to mention that like all tests are usually being ordered by providers. There are some instance or occurrence that nursing will be able to order certain tests and procedures, but that have to require what we call like, NIP or NII, like nurse-initiated investigation or nurse-initiated protocol. So those has to be going through kind of like, nursing scope kind of like checks to making sure that these are adequate and there's like specific guidelines and protocols in place in order for nursing to be able to place those orders. So and that's one of the reasons I think why we also have professional practice team here to kind of help to listen in to see what the current status or current workflow for your clinic and see what are the options for us to go forward if we're proposing, for instance, these tests could go back to the provider's work, meaning that the providers are who are currently on these requisitions, will they be able to kind of take on to ordering these tests in future state?
So what you're suggesting, Hilda, sorry to interrupt, is like a slowing down of the workflow, right? Like essentially what you're saying is you're going to take us from uber efficiency and put us in a bog. And so that seems unacceptable to me. Like the whole point of Cerner is to make our workflow smoother, was my understanding, easier, at least to a certain extent. And this sounds like the opposite. It's quite archaic. So what I need from you is a very big group of you here. You're almost as many of you here as there are clinicians providing our program's care. So you guys got to take this away and come back with a suggestion and tell us how to do this so it's seamless. We don't want to do more work.
Absolutely, we totally hear that. And that's one of the reasons why we have a huge group here today to open up the discussion. Kate, I think you have your hands up.
Yeah, I do have my hand up, and just to reintroduce myself, because there's so many of you I've never met before. Kate McNamee, Director for Professional Practice, Nursing and Allied. So I think that there's a really important piece that we have to pay attention to here is ensuring that nurses are working within their scope of practice. And so that is one of the key points that it's very important for us to pay attention to what the current flow is, so that we understand how we ensure that we're not asking nurses to come outside of their scope. And so what tools, resources do we need to ensure that we are getting them to practice safely? So I'm sure we all respect that and appreciate that.
The current state is no nurses working outside of practice. These are requisitions that are stamped by us to send the clinic, right? So nobody's working outside of the scope of practice, nor are we asking them to. We're just asking Cerner to do what's currently done without making it worse.
Yeah, I hear you.
Okay, yeah. Thank you, Dr. Sampath, for that comment. And then what we are also trying to hope to get today is to have that discussion, have the understanding of your current workflow, and then going forward, absolutely, I totally agree that we have to kind of like figure out some kind of way for us to kind of smooth out the workflow in the future in Cerner, knowing that these are kind of like standard guidelines or standard tests that all your patients are getting. So we will definitely work together with the professional practice team to see what are some of the options that are available for us to making sure that we're not crossing any kind of like scope boundaries between the nursing and the providers and all. So I think what we're hoping today is really just to kind of go through the workflow of the clinic, have the discussion, knowing what some of the concerns from the provider side and from the nursing side and from the allied health side as well, and then bring that back. And then we're definitely gonna do some investigation and see what are options that that are available as well. And that's one of the reasons why, like I said, the professional practice team is also here, is for us to kind of explore some of the options that are available. So at the moment, I think we are still kind of doing some investigation, putting out there your clinic is not the only one that would have nursing also placing orders and doing things that are normally not in the inpatient nursing kind of like scope. So I know the professional practice team is involved in that conversation with other clinics already.
Sorry,
So,
Hilda, can I interrupt for a moment? Sorry. One more thing, when we're talking about nurses writing some, not writing, pardon me, but ordering some of these tests, at our previous meeting, you had mentioned if a nurse does order any of these tests, that they would need to be co-signed, and then each and every one of those tests that I may be ordering would then actually go to a physician for them to co-sign. Can you talk a little bit about that, just so we're all on the same page here?
absolutely. Thank you, Raj, for bringing that up. So yes, so in future state Cerner, there is still kind of ability for nursing to kind of place orders. However, because nurses are it's not within the nursing scope to be placing orders without, like, you know, a guideline or a protocol to kind of dictate that it's within their scope. So if they are ordering things that does not have proper guidelines or protocols, and this, for instance, like right now you have verbal orders or telephone orders. So the nurse are placing orders on behalf of the provider, which is kind of like similar to what the current state of this your clinic workflow would be. So if the nurse is placing these orders on behalf of a provider, each of these orders will be routed to the provider's message center. I think Mary has kind of show you the message center inbox, which is kind of similar to like an email on your inbox. So there will be kind of like a message saying that, oh, hey, for this patient, this order has been placed by the nurse or by somebody else, right? Who is the patient's under your care. Do you approve of this order? So you need to kind of what we say co-signed this order. So knowing that for your clinic, these they have a lot of standard blood work or diagnostic imaging and tests like that. So you're going to see a lot of these. Thank you, Mary, for showing this. So you see a lot of these messages. So so the orders, each of the orders will come into one message, and then the doctor will need to kind of co-sign, like approve or refuse of these orders. So that's still
so Hilda, currently nurses aren't ordering these tests, right? These tests are the requisitions are signed by ourselves. So why in the future would nursing have to do that? And then somebody else could, like, it's just 2 times the work. I don't understand that. Why couldn't we have a standardized system whereby patient comes in and the tests are ordered in the exact same way we're doing it now? Is that not possible with Cerner? It's not sophisticated enough to do that?
That's a very good question, Dr. Sampath. So there is a way for the messaging not to come through. And so when the nurse is ordering it, there is this box that's asking, like, where is this nurse getting this order? Whether it's going to be a telephone, whether it's going to be a verbal order, and there's an option to say no co-signature is required. So anything that is verbal or telephone, it requires a co-signature, and anything that is within the nursing scope, or like I mentioned earlier, or if there's like a DST, like the decision support tool or protocol or guideline that is will support the nurse. Thank you, Mary, for showing this. So here, there is an option for no co-signature required. If the nurse, when she or he place the order, then select no co-signature required, there will not be a message going to the doctor's inbox to ask for a co-signature. However, anything that's phone or verbal or paper fax, those will require, sorry, not paper fax, phone, verbal, or co-signature required will require a co-signature from the provider. So the only way for us to kind of go through this without having the doctor to having to co-sign, normally it requires these protocols or guidelines to be developed so that it will be within the nursing scope to be doing this.
Sorry, Hilda. I just heard in the previous comment that the nurses aren't putting in the orders. So I don't think this would apply, right? Like, the providers, if the nurses aren't, which I thought I heard in that last comment, the nurses aren't putting these orders in, then the providers can, and there's no message sender signing required.
Yeah, so something I'm hoping to clarify, because Hilda, from what I'm hearing from Dr. Sampat, the nurses aren't currently ordering any lab work or diagnostic tests. They're all, it seems to be all a pre-filled, standardized referral requisition. I'm just wanting to confirm that nurses currently at the bariatric clinic are not placing any orders, and unless I'm hearing it correctly.
That's correct. I mean, the nurses are not doing it. We as the clinicians have sat together and created the protocol, which involves all patients coming to the program getting CBC, ultrasound, etc. And those are pre-printed orders with our name stamped on it, pre-approved. All the clerk has to do is to put the sticker of the patient's name and addressograph on the form and fax them off. So it doesn't require any work involvement from Raj, our nurse, or the clinicians prior to seeing the patient. So they're pre-printed forms and pre-approved. Is there a workflow that Cerner can provide that does not involve nurses or physicians and on a pre-approved order?
So it sounds almost like a power plan to me, unless I'm mistaken.
Current state is not, so being a Mila, so just to give a little bit more context to the situation current state. So Dr. Sampath and Dr. Nguyen is correct. So current state, so the nursing is not ordering these tests for the patients. However, these requisitions do come from the clinic. So what happens is that these patients get enrolled into the program, and then Raj will then there's already copies of paper requisitions with blood tests, diagnostics that are already signed on these paper requisitions, and it is Raj who is sending these.
Sorry, Hilda.
Yeah.
It's not me that sends them.
Oh,
As I mentioned earlier, these requisitions that are already signed by our physicians, it's our unit clerk that arranges these tests after the patient has started in our program.
Okay, got it. Thank you, Raj.
This is no different than the ward, right? I will write an order. Or there's, for instance, low molecular weight heparin after a colon surgery. There's a standardized order template. It's all pre-signed. The unit clerk faxes it. No different. There's no nursing involvement.
Yes. So in the future state, somebody needs to enter these orders into Cerner. So that's where we are trying to get at, right? The ordering part, because right now these orders are already on a paper requisition with a signature. So the clinic just kind of put a patient label on and then send it over to the patient, because these are standard tests that the clinician, like all the providers, have agreed upon as that is needed for all patients enrolled into the program. But in the future state, in order for these labs and diagnostics to be entered into the in Cerner, absolutely we can create power plans and with orders and all that, but we still require the provider to go into the system to place these orders. And I think that's where we are trying to figure out, because right now providers are not the one, quote unquote, physically writing these orders or even signing them, because they are already pre-signed on a requisition that is within the clinic. So
doesn't that seem far less efficient to you? I mean, does anyone in this group think that seems more efficient?
So in future state, I think what Hilda is referring to is that the clerks cannot place orders. The clerks cannot submit anything on behalf of the provider. So and then they wouldn't need to fax anything, right? Because these orders are going to go to electronic, like scheduling queues, or to the lab or MI. So think that's where Hilda's coming from. And I think now I kind of understand why you were showing the nurse piece, because if the provider isn't the one submitting it, technically the nurse could do it on behalf of the provider.
So these patients are pooled patients that will eventually be triaged to one of the many surgeons. So it's impossible to assign one surgeon to log in at the end of their workday just to order all these things for each patient.
So this is Johanna. One of the things that why we were showing you the triage process is because through the triage process is easier to place those orders when you are just accepting the patient. Now, completely agree. This is going to be a major change to do the CPOEM or the computerized order entry by the physicians. It is a requirement. The pre-printed orders, generic, it doesn't exist in the future. It exists on the context of a patient, and the system does a verification of any allergies or any contraindications on any other things, and to send all those requisitions directly to the departments that need to know about them. So it could be part of your triage, but at the moment when you're accepting the patient, there is a way to do it faster for physicians or nurses, whomever is doing the triage, to place those orders on protocol, like they were mentioned before, a power plan.
Can someone show us this, like a version of this power plan, so we can maybe understand it? If if there's like if there's 40 patients that come into orientation, what I'm hearing is that at the end of the orientation, we don't know which surgeon these patients are going to go to at this point in time. They're just in orientation, but we're ordering all this blood work and ultrasound, et cetera. So for instance, one of us is going to have to sit down and enter in 40 types of blood work, 40 ultrasounds, 40 this, 40 that. Is that what I'm hearing at the end of our day? Or is the power plan something like
The power
one
plan
click and everyone's on?
can contain blood work, imaging, and all the tests that you require for each of the patients, but the orders are individualized by patient. So if you have 40 patients that you're accepting, you will have to place 40 power plans for each of those patients.
So on top of on top of our 15-hour days, you're suggesting that we then sit down at the end of that day and put 40 more orders in.
Well, what I am saying is that the biggest change coming with Cerner, it is the computerized order entry by physicians, which means that those orders are not pre-printed, pre-sealed orders, but they are in the context of the patient, and the only persons that have the right to enter orders are providers, which include physicians and includes your nurse practitioners, and it could be as well protocolized by your nurses.
And since we don't know who these people are eventually going to end up with, if say I am the one on Monday, this orientation, I'm the one to enter all the orders. Now I've entered 40 patients worth of orders, but only 10 or 15 of them are eventually going to come to me. Am I now responsible for all of the blood work and ultrasounds? Because we don't know who they're going to go to yet. Central referral only happens after the patients have completed their preconditioning to be eligible for surgery. So now I'm entering all these orders, and by the college rules, I'm responsible for all of the abnormalities that are found on these orders on patients who are not even my patients.
Well, if how you do it today, because you were saying that you do have individualized stamped orders by physician, so it just kind of the same workflow. Now, if at that point nobody knows that who's the physician that is going to go to, we also have a solution that creates like a pool of results, and just like the PAC or pre-admission clinic, where all the results, you don't know who is going to be the anesthetist that will be that day reviewing all the tests. It goes to a specific inbox that is shared, and different physicians will look at that information. When it's looked at, then it will disappear from your message center. So it is a shared legal responsibility if you wish to follow up on that workflow.
Okay, that's a bit helpful. I still struggle with the individualized order entry. Now, here's another suggestion. Can we just do this through our offices?
Yes, I was
So
meaning.
instead of using the Cerner at all, can we just, we'll have our patients registered, and then we can continue to send an e-fax to the hospital with ultrasound requests and an e-fax to the hospital with blood work requests.
Are the patients registered privately, or are the patients registered publicly? Like they are private patients, or they are public patients at that stage?
It's a good question. I don't know for
They
sure.
start out as private patients are being referred to the surgeon, but then the referrals, once they come to us and the patient attends an orientation, then they get registered in PCIS, it becomes public.
So then the workaround, Raj, is we do it through our offices.
As long as the patient is still in the private environment, I think that we could discuss about that possibility. But once that the patient is registered publicly, the thing is that the requisitions go faster for your patients when they go on the electronic system.
Sorry, why do they go faster?
Because this electronic goes directly to their queue, electronic queue. There is no paper to deal with on at the imaging side or at the lab side.
But now that the desire is to have all the fax referrals go through the bariatric clinic, then our private offices don't have the information. So in order for us to fax the referrals to our office, we have to get the information back from the bariatric office, which is even more work.
I think Hilda mentioned that all the physicians, as long as you have practicing privileges at VCH, will have access to Cerner for viewing.
Yeah, that is correct.
But what I'm saying, Raj, is if we're registered in our private EMRs, then we can still do the bulk, ultrasound investigations without having to go into Cerner, log in, do all this. This could just be done automatically.
Would that then mean the central referral system won't change? The referrals will stay coming to the surgeons?
I mean, that's the potential downside here.
Can I just ask something, Hilda? Last time we met, I asked whether there was any scenario anywhere at any facility or hospital where Cerner has been established now. Is there any program where there are certain standards like we have here, certain protocols that can just be built in without having the physician having to order or the nurse having to order? I don't know. I find it hard to believe that hasn't happened anywhere yet.
It is not. It hasn't happened anywhere because it is the college who decide who has the and professional practice who can tell who can place orders that will be active in a patient chart.
No, but we're not saying that it's not the physicians placing the orders. We're just saying, is there a way that the physicians can bulk order, right? So that they don't have to do individualized order entry.
No, the full point is one of the principles of the implementation of the electronic record is to get the safety to do the personalized order entry.
Yeah, so I think we've gone from, we keep saying the term future state, but this seems prehistoric to me.
With the power plans, which are basically your pre-printed orders, there are like ways to customize those to whatever, like if you always are ordering the exact same labs and whatever diagnostics, you could set that so then it becomes like a one click versus going through the plan and the 40 orders. So there's ways to make the ordering more efficient, but ultimately the order needs to be placed for each patient.
I think the other thing that's a bit tricky for us is within all of these tests that we're ordering, it would never be the surgeon ordering the sleep apnea testing. It's never the surgeon ordering the blood work. That's our endocrinologist, but both our endocrinologists don't have practicing privileges here. I think, Hilda, you were going to take that back to the team and find out if there was any workaround for that. Because there won't be one person ordering all 4 tests.
Yeah, no, well, bringing that information about Dr. Harris to Nancy, and Dr. Eric Grafton, the Chief Medical Information Officer, is also following up on that, on the privileges.
Yeah, so Johanna, who's our director for the provider team, I've reached out to them, and then as Johanna has mentioned, we have brought it up to Richmond leadership to kind of explore what are the different options for Dr. Harris when Cerner does go live. What are some of the options for him to continue with his practice?
It's Iqbal Ahmed. Can I just ask a quick question? When referrals come in from GPs, we often ask them to, do certain tests, fill out some requisitions or questionnaires. Can this be linked? Can this order list that is standard for all these patients, can it be linked to the referral from the GP? So therefore, the referring doctor is the, is the ordering doctor.
So Dr. Ahmed, can I just ask for these lab works and tests that are coming from the GP, are they not already being ordered by the GP for the patient? Are they only faxing it to your office for you to order?
No, I'm just trying to address this issue of the surgeons not wanting to order them, the nurses not, so someone has to order these tests, right? And so I'm just saying that why can't the referring doctor, not being the ordering physician, and the standard list of blood tests, etc., are on this sheet that the referring doctor orders.
Absolutely. I think that's definitely a possibility. An option as well is to go back to the referring provider to have these tests done, because normally you're correct. There are some criterias that each of the clinic can set to say that, hey, before you submit your patient or enroll your patient into our program, you have to have a list of these tests done with results before these patients can be kind of accepted into our program or into our clinic. So they are.
If I can make a comment, I mean, that's what you propose good. Unfortunately, when they are referred, they wait 24 months on our wait list until they get seen by our team. So by the time they get into our program, their blood work is 2 years out of date. So we, yes, we can say your patient only can come to our program unless they have all these tests, but then it's the wait list is the problem.
But I think we can work on that, can we not? I mean, we can. I mean, you can tell us, but I mean, there is a point in time when they move from being on the wait list to coming in as such, and can the program not work on that aspect?
I mean, it's I'm not sure what's more work is to at the time the patient go into our orientation is to fax back to the GP saying, okay, now it's time for you to refer to send us all these tests. Is it more work to communicate to them to make sure these tests come in and wait for the tests to come in before we do orientation? It's more efficient to have a pre-printed order and just make sure everybody gets the test we want.
So I think Mary was showing a power plan in our system earlier. So what a power plan is it has all the orders. If we are saying that there are some standard testing and blood work that are being ordered for your patient, all the patients who got enrolled in the program, we can build something similar to this, which will contain, and right now you see the boxes are not checked. We can pre-check, meaning that these orders will be automatically ordered. So we can pre-check these orders when we're building these power plans, with a set of standard blood work, with a set of standard diagnostic imaging tests. So as soon as you search for this power plan, this will pop up with all these orders already pre-checked, and all the doctor has to do is to click sign, and then the orders are placed on this patient. So that is one way for us to kind of make this process a little bit easier and less work for whoever the ordering provider would be. So that is also another option that we are going to be proposing, because this again is what we are going forward with in terms of what we call CPOE, which is computerized provider order entry. So as Johanna has mentioned earlier, all these tests, if they're ordered in Cerner, like, you know, the diagnostic clerks, they will be able to receive these orders right away, and they will start booking these patients right away. So there's a lot less work on the diagnostic side, on the lab side. So if we're still giving out paper requisitions for lab requisitions, right? Each of the orders, when the lab tech gets the order, they still have to manually enter these orders. There's like higher chance of, like, you know, transcription errors and also delay as well, depending on when the clerk or the tech, lab tech gets to the paper requisitions before they can enter these orders into the system. And so is the diagnostic technicians as well. So we're hoping to also provide, like, you know, a faster and more seamless process for all patient, like all departments as well. So this is also why we are also proposing the CPOE. So I think for the batch ordering, unfortunately, it's not available in Cerner, but we do have these, what we call power plans that can be already pre-built into the system. And then you can also favorite these power plans. So when you're searching for them, you don't even need to search. It's in your favorite folder. You open the patient's chart, go into your favorite folder, open up the power plan and sign for it, because all the orders are already pre-checked. So you don't even need to kind of click and select any orders as needed. Unfortunately, this does need to require the provider to go into the patient's chart to have this done. So I think from what I'm hearing is, so this is one option. I just don't know how, whether this will work for your clinic.
No, if I can ask a question, no, this solution won't work. But I'm just going to ask a question that might seem unrelated to what we're talking about, but thinking of a solution for this. Earlier, Mary, you mentioned that there are things you call an internal review with another clinic. Does that internal review interface with EMRs, outside EMRs, or is it only with other Cerner systems? Is there a portal where the referral of the patient and the demographics can be exchanged with an EMR through, say, NHL7 protocol?
I'm not quite sure.
No, so no, we don't have any interfaces with EMRs, and even less with our ordering. There is not something like that exists.
Is there an opportunity to create one? Because that would solve a lot of problems.
If there was a conversation about interfaces with EMRs at the beginning of the project, it was just put down just because of the variety of EMRs that we have in the province or with our physicians. So at this time, there is no any space in the project that they will consider to do an interface specific with any of the EMRs, private EMRs.
Okay, so I think at the moment, I don't think there's a way for us to come to a consensus, knowing that I just wanted to kind of summarize what has been discussed here. So there are a few options that are being put out to the group earlier. So one of them that we have proposed, obviously, is to have the providers placing these orders using power plan that we can definitely build in our system. So unfortunately, this is different than the current clinic workflow, and it does add on to the providers workload. So we did kind of like capture that as well. Another option that we are also trying to explore is to create, obviously, like, you know, with help from professional practice, to see if it's even possible for us to develop some kind of like guidelines or protocols to dictate that there are certain tests that are within the nursing scope that nurses can place, like for the providers without the provider having to co-sign for these orders. Unfortunately, we do need to kind of like do a little bit more investigation with that option, knowing that there are some higher up that is also like, you know, the nursing scope criteria and all that. We need to making sure that everything that if we are proposing going down that route, that is within the legal scope of nursing as well. So, but we would definitely wanted to explore that option as well, because that would probably mimic your current state workflow best. Another option that I've also heard is to kind of like put the request back to the referring provider as asking them to have these tests and diagnostics orders done on these patients as this is part of the referral process. But also knowing that there's a 24-month wait on these patients. So that will require the clinic to reach out to the referring provider and then getting these tests done again. Excuse me. So that would also kind of like delay the process of these patients and their treatment as well. So we also capture that as one of the pros for that option. Have I missed any options that is being proposed here today?
I think that's a really good summary, so Hilda. I just do want to point out that like if we do put the ask out to the referring doc to do the test, it then puts the onus of the referring doc to review and be responsible of any abnormalities found in any of the tests, which then might restart the the wait time and whatnot, right? Because then if there are abnormalities, then that will have to be resolved before they are accepted into the program.
Okay, thank you, John. We'll also capture that as one of the pros as well. Can I just kind of get a sense of like going forward, is there any recommendation from the clinic with the three options that we're proposing?
I think we might need some time to digest and really sit through it. I do understand that there's certain advantages and disadvantages, as you mentioned. We might take this back to discuss, and then we'll engage with you again just to talk through this.
Perfect. Thank you, John. We also going to be, like I said, we also have to do some work on our end as well to kind of explore, with the nursing scope route as well. So we're definitely going to be working with professional practice to see if there's other options that are available. Like I mentioned, there are other clinics within Richmond that also have very similar issues, current state. So we're also going to be connecting with those clinics to see what other options that they are also exploring as well. And hoping that we can have like a standardized or enterprise kind of workflow for these clinics that have similar kind of issues and workflow. Kate, you see your hands up.
To that point, when we do have places where nurses are ordering it, is because it's part of a certified practice that they have. So that is not sort of the mainstream or norm that we would see. So these are very select situations.
And just to add on to that, we'd also want to be mindful of the nurses' capacity in workflow, because this sounds like it's going to be a significant change in the nursing role at the bariatric clinic. So that's something we'd also have to explore.
I think if we go forward, Cerner, the only solution is what Dr. Ahmed suggested, is that the clerk filing the referral fax will have to send back to the GP saying that we do need an ultrasound and all these tests to be done, and we will have to use the tests that we receive at the time of the referral.
Okay, Dr. Nguyen, thank you for that. So we'll take that into account as well. And then,
Sorry, Hilda, just to note, if that's the clinic's preferred option, we still should look at the institutional entity solution because I believe that as long as that institutional entity is carbon copied on those results, it will flow back. So then the clinic would still be able to review those results from the orders from the referring.
Just on that point, I mean, is it possible to trigger the testing, at a later date, because Dr. Nguyen is right, it's the 2-year time frame. Is it possible to trigger the testing at the time when they come for orientation? Is that possible? I don't know, but it's something to work on.
And Dr. Emmett, you're talking about having these ordering for the tests and diagnostics from the referring provider side.
Yeah, I mean,
have a delay,
a
timed at a later time requisition for these tests.
Yeah, I mean, we don't want to say just routinely, oh, do it 2 years later, but we want to do it at a point, like when they come for orientation. That would be perfect. If somehow we can work that into the system, it would work well, because then we have an ordering physician. The results will go back to the ordering physician, but the results will also come to the bariatric surgeons and the team, so those two aspects are dealt with.
That's a very good point. And I think Mila also mentioned a very good functionality in Cerner as well, which is what we call the institutional entity or the clinic inbox. How earlier I was saying that like any test results or any orders usually go to the ordering provider's inbox for them to kind of co-sign or review for the results. There's also this clinic inbox or institutional entity, which is for the ordering provider. They can CC this clinic inbox, and then all the results that are being done on the outside or in the hospital will be also CC into that clinic inbox. So the clinic provider or the clinicians also have a way of knowing that these tests are being done, and then if there's any abnormal results that are coming back as well too. So that is also another way for our clinic to be tracking these results, even though it's ordered from the outside.
Hilda, I think there's another solution that I'm thinking about now. I don't want to bring it up yet because I'm not sure it's feasible, but I'll run it by my team internally and we'll get back to you on that just to simplify things. It may be something that we can move to that satisfies everyone's requirements.
Okay. Sounds I'm really happy to hear that there's another option out there. So Dr. Sampath, I'll let you converse with your team, and then if this is something that is in agreement with your team, please feel free to let us know, and then we will definitely bring that into our CST team and see how we can move forward with that.
I have a question. You mentioned that the clinic inbox can be CC'd. Does that mean that the clinic will have a provider address on Accelerus?
Unfortunately, it will be only in the Cerner message center inbox. It would not be CC'd into Accelerus.
Because if the GPs are going to be ordering these missing tests or to complete it, they're doing it from an outside EMR, and the results would come into the system through Accelerus, and so it has to be CC'd to a particular person, I suppose.
Yeah, so that's what the institutional entity solution does. So it'll bring those external results into a shared inbox for the specific clinic.
Right. So there is an entity that has a shared box. So when you CC a copy of a result, it's not to an individual, but to the clinic. Is that right?
That is correct.
Yeah.
So this is something an external lab can do. Is that correct?
That is correct. As long as the ordering provider has CC'd your clinic, like on the requisition, they have put your clinic down as like one of the CCing providers. And then those results will come back to the clinic's inbox so that all the providers and clinicians will be able to see those results, even though it's done at the outside facility.
Okay, thanks.
So I think we have a really good discussion here with the team. I think we have heard all the concerns from all the clinicians and have kind of found out, like, some of the proposed options for future state. At this point, I think there's further discussion that is needed. We definitely know that, within your team, we just want to provide all the information that is available in regards to what the future state functionality of Cerner can offer, and then also to hear your concerns. And then sounds like there might be other options that the clinic might be also exploring as well. So, so we will be definitely in touch with your clinic, and then hopefully we'll come to a consensus of a workflow that will work for everyone. Is there any other questions that regarding the referral process right now for the ordering part, or just in general? Okay, so I'm not hearing anything. So just wondering, like, for time's sake, does the clinic still wanted to continue with our workflow demo, or is there anything in particular that you want us to review first, knowing that the surgeons do have a time limit and they need to go to see patients? I'm not hearing any requests. Then we're going to continue with our clinic workflow demo and going through the questions as well.
Hilda, I don't know if you can hear me. I've got to jump off the call, so I'll let you guys continue. Thanks for including me.
Yeah, no problem. Thank you for being here, Dr. Sampath.
Thanks, bye.
Great, thank you for that robust conversation. Carrying on with the demo, so we've left off from Hilda, the clerk, putting in a indexing patients a referral package, and now I am doing the triage. Let's see here. So earlier I heard that if we can do a order when we do triage. So I'll just show you what that would look like. So I have the location as the, it will be your location, but for the sake of this demo, I've used VGH Gender Surgery Program. The referral status will be ready for triage. Hit the run button, and we have this patient here. All right, so once we have this patient, I would go into the, what we call an M page, provider view. Click over to the referral triage tab, come over to the documents, and you will take a look at the referral package, view documents. Same as how a nurse would go through it. Review their information. You can come and review their notes in the document section. There's been previous notes set up. And then this is where we would add the order. So earlier we mentioned some of the favorites, so we can show you how this can be set up. So it's easy. Couple of clicks for you. This can be customized as we call it the 80-20% rule. So 80% of the time, what do you usually order? So we can have that preset, and then you just click order for signature, and you can click sign. This is the second time I put in, so there are some guardrails in Cerner, so if there's any duplicate pop-up box, which is a gentle reminder to let you know this has been put in twice. You can hit remove. there is quite a bit of them. So in summary, that shows you what a power plan can look like and how you can customize that. And I believe if that's something that the clinic have an appetite for, then the order set team can help go through the process where we go through requirements gathering, design, and validation session. I'm going to pause here and ask if there's any questions from the group. All right. So once you are satisfied with the patient's information and you're ready to accept this referral, then put in a accept order. So like Hilda said earlier, any yellow box or mandatory fields, and here is where you can determine how urgent the patient needs to be seen. For demo purposes, I'll write 24-hour and the type of appointment. All right, so for this one, this is something we can discuss with you right now in terms of the appointment request type briefly, and then the designs. For the scheduling team, they'll dive deeper into the type of appointment request that you will need for your clinic's scheduling needs. So we will click order ready to sign. Apologize, these are the earlier. Let me see if I can get rid of them. I'm going to multi-select. So it's how you normally use a window computer. You can multi-select by hitting Control. Okay, no, that's not one. See if that will work. I still have some PTT. You can see on the right, we have what we call a refresh button. Just click. You see the accept referral order. The accept referral order has been placed. And so the next step of the process is going to pass the ball to the clerk, where you can see that the request shows up on a request queue, ready for the clerk to schedule. So I'll stop share screen and let Hilda take over. Sorry, Hilda, we can't hear you at the moment.
Sorry, I didn't unmute myself. So, so now we're back to the clerk. So I'm in what we call the scheduling appointment book. So this is where the clerk will usually work out of. So this is kind of like, you know, their current state of their scheduling. So in the bookshelf, as what we call here. So right now we are in the BGH gender surgery bookshelf. So this shows you all the appointment that's booked for this clinic on the different days. So you have a calendar here to kind of toggle over to see for tomorrow, what are my schedules for this clinic, and so on and so forth. So you can check different dates and look at the schedule for each of the individual dates. So right now, we're just going to go by today's date, which is July 20th. So I can see all the appointments that's being booked for my clinic. So right now there's only 3 appointments for the nurse, and then there's other providers. So these are the resources built that we have like social worker, PT, and dietitians, and all that as well that can be built as part of our scheduling requirement build as well. So I won't go into too much detail. I'm just going to go through to booking of the appointment for the patient that just got accepted. So now I'm in what we call the request queue or request list. So for this request list, I'm only looking for the gender surgery request. So that is any requests for booking into the gender surgery clinic. As you can see, I have quite a long list of requests that are needing to be booked. So when I click on find, this will update all the requests that are coming through. And there's also another way for us to do refresh as well. So right now I'm going to look for the patient that Mary just placed the order on. So there are all these columns that you can also filter. You can filter them by name, by their MRN, or by the enter date. Enter date meaning that is when this order was placed. So I'm going to use the enter date to look for the order that has been ordered most recently. So as I can see for July 20th, there is this patient for the RHS MBS clinic, one patient that Mary just placed the order for. So I know that now I can proceed with booking the patient. So I'm going to right click on this request and select complete request. So there are some required fields for me to put in for this patient. So I'm going to quickly put those in. So now the request will be put forward into what we call the work in progress box. So this is how we can now proceed with booking of the appointment. So each of the individual appointments has already been built based on which provider or clinician this appointment is based on. So for instance, for your clinic, you will have nurse appointments, you will have social work or mental health clinician appointments, dietitian appointments, and psychiatrist appointments as well. So those will be built based on the appointment or the order that's placed for the scheduling. So for this appointment or this request is mainly built or based for nursing appointments. So that's why only the nursing resources is pulled forward here for me to book. So I know I'm booking into the right resource. So for here, any of the yellow are the available times. And I can see these are all the block times that already have patients booked. So the next available I can see here might be the 1 o'clock. So I'm going to put forward over there. And I'm going to put this patient to book for the appointment for the initial assessment appointment for 45 minutes at 1 o'clock. And now, once I've put in the patient here, this still need to be confirmed with the patient. In order for me to confirm with the patient, normally your clerk will probably gonna have to call the patient to say, oh, so for Mr. or Mrs. So-and-so, we have you looking for an appointment with a nurse, with social worker, clinician, and psychiatrist. And then we have July 20th at 1 o'clock, 1 p.m. available. Can you confirm with the time? So once the clerk gets the verbal confirmation from the patient, then she or he can confirm the appointment. So now, so I clicked on the confirm button, and then there's some fields I need to also populate. So initially I have created a referral encounter in order for this patient to go through the triaging process. So now I'm going to use the same encounter because this is for the same appointment. I'm going to modify that to make it into what we call a pre-outpatient encounter. So I'm going to pre-register an outpatient encounter for this patient. So this is just a pop-up to say that this patient has an active inpatient or LTC encounter, which is fine. And then under the encounter information, I'm going to select pre-outpatient. There's also option of selecting what we call pre-recurring. And for pre-recurring encounter or recurring encounter, these are the encounters that patient has a series of appointments. So, so if your clinic does use like a series, like for instance, I know your clinic does for nursing, they have every 3, 6, and 12 months appointments. That can also be an option for using a pre-recurring encounter. But if it's only a one-time thing, then we're going to use the pre-outpatient encounter. So right now I'm just going to say pre-outpatient. And the estimated arrival date, so I know it's the patient has confirmed for today at 1300. So I'm going to write down that's the arrival time of the patient and complete my booking. And now, as you can see, my patient's appointment has turned from yellow to like a teal or aqua color. So that has said that the patient has confirmed the appointment. Okay. Right, so Mary, I'm going to pass back to you to go through the next step of the workflow.
Great, thank you. So now going to mirror what the scenario of the clinic is. So what Hilda did would be an example of that would be the clerks contact the patient. They're up for orientation. We've booked them the orientation meeting, and that's when the when Hilda made the appointment, and then when she confirmed, that's when the patient's committed to attending the orientation. So then going through that route, we're going to see the patient. So they've gone through orientation, and now we're going to fast forward and say we're going to do our first initial intake, or the first initial assessments. So I'm acting as a RN right now. This is my landing page. This is the home page here. You can always come home with the home icon. To the left, like I said earlier, it's the inbox, message center. And to the right is what we call the ambulatory organizer, or the AO, which is your day planner for either yourself or for the clinic in whole. So here you can see the time and the resource or the personnel that the patient has been booked with, the duration. That duration can be customized, and that could be dive deeper with the scheduling team. Patient's name, as you can see, it becomes a hyperlink when you hover over. That will expand more patient demographic information, the reason for the visit or the appointment. And you'll see the status on this column where it's confirmed, or patient's been checked in, and so forth, and any notes that you want to have attached. And you can also comment new notes in this, or this is your opportunity to add new notes as needed. You see here, we don't have the patient that just scheduled, and that's because I haven't refreshed my screen. The information was a bit stale for 2 hours, so I just refreshed this. You see on July 20th, now we have patient 1 coming in at 1 o'clock. So you can go into the patient by clicking on their name. The hyperlink will open up their chart. If it's your first time charting, I'll ask you to establish a relationship for this encounter. And from here, you can access documentations, lab reviews, any PPO or pre-printed order that the provider may have put in advance. That would populate here. I'm going to give you a sample of what an intake form looks like for the enterprise view. So we go into the ad hoc button. The ad hoc folder, think of it as like an electronic folder or file of all the forms we have. Okay, thank you, Dr. Nguyen. Have a good day. In Cerner, and we can access it by pressing that button. We'll do the adult intake history folder and go through the ambulatory adult assessment. We'll click chart. So this form is used by multiple clinics across the all Cerner sites. We have some key fields here, like chief of complaint, accompanied by who are they visiting with, patient's problem, allergies, measurements. We could put weight here, and if we put the weights, heights, the system will also calculate the BMI for you. Demo that. All right, and also doing some conversion between different units. You can also put if it's a phone interview, we might not be able to do things like temperatures or heart rate, but you do things that is needed for the clinic or adopted for the clinic workflow. And to save this form here, this power form, we'll click check. If you're not done, you can hit the save button. And if you need to come back to that form, you can go on the left menu, go to form browser, the power form that we're filling. Click on it, right click, and modify. And you can continue charting. If you're done, I would hit the green check. So that is the power form. Another area where a nurse can document or allied health can document would be what we call interactive view and INO. INO for INO, we sometimes short form interactive view into iView. So this would be useful for something like when a nurse goes see a patient post-op day 1. They will come here and can measure vital signs. They can put in any adult education they have provided, discharge planning, or sorry, discharge teaching, anything that would apply during the conversation with the patient in the inpatient unit. You can also chart according to the system. It goes from head, generally goes from head to toe. Okay. There is an area where you can also document incision wound sites and pin site. I'm not going to dive into details, just being conscious of the time we have left here. Another area to document is the documentation tab. I just want to show you here. For a nurse to add a documentation, come here, type would be a nursing narrative notes. There are a variety of templates that's pre-built, and as a general rule of thumb, with Cerner, there's things that you can do favorite. So for this nurse, I have already favored a free text note, so I'll just click into it, click OK. Now, during our site visit, I had the pleasure of reviewing some of the templates that the clinic is developing. So I'm just going to pull that up right now. One of the template that I have created in or trying to mirror in the Cerner system is called the RN Pre-Op Medical History Fillable. This is just a rough draft. More personalized. So let's just do that one more time. I went down too fast. Okay. Can you see my screen okay side by side?
Yep, we can see it.
I'm going to show you what we call an auto text. Auto text means you're calling out a template. It's another way of saying it. We have short keys or hotkeys. So for this demo, I hotkeyed it as comma, capital MBS or Metabolic Bariatric Surgery Clinic, RN Pre-Op Med History, but you know, it will auto-populate some options for you to choose. Click enter, and you will see this form jump out at you. Try to mirror it as closely to the actual form you have. And this is what we call an auto text. We do recommend that you create it in-house, and we can show you how. It's very easy. I did it this morning. Quick and easy. And the advantage of creating this in-house is that you can modify it whenever you need or adapt it to your needs. Say there's another field that's needed on this form, you can always just update it, and that can be done through this edit button. You look for your templates and click edit, and you go from there. Okay. Don't worry if none of this, what I'm saying, is sticking. We will provide a very comprehensive training for you. And after go live, we will also have on-site support that can help you create, build, dismantle these templates. Another advantage of this template is we have something called token or smart template, where it knows to pull information from the iView or any other areas that you have charted in Cerner. I know I said a mouthful and I think I need some water. Does anyone have any questions? Thank you for joining us, Dr. Harris. I'm just showing the auto text or documentation that we can build, or we can show you how to build for the clinic. That can help speed up documenting. All right, so that is what I have planned to show for nurses with Adrian here. Let's see, I'm just gonna talk about ally health. So log into ally health. Let's see. I'll look for a template. If I miss anything, Adrian, please feel free to step in here. So I know for the, sorry, did I hear something?
Oh, I just said, sure.
Okay.
Anything.
Sorry, I probably talked too fast. So for the registered dietitian, they will also have what we call the eye view as far as their cerner. They can also pull up note template as well. And so I'm just going to look for a template that we have. It's part of the enterprise. It's called the nutritional care plan follow-up notes or the initial notes. So we'll take a look in the initial note and see what's there. So this is a generic template that we have for the entire enterprise that can access. So you can see the information here may or may not be relevant to your clinic. And again, that's why I recommended earlier to use to create your own template. So it's more customizable to your needs. Does anyone have any questions regarding documentations or creating these templates? Okay. And in terms of social workers, they also have access to what we call a dynamic document and also can create these auto text template as well. Well, that is all I have prepared for the demo for this presentation. If someone else feel that they'd like to explore, we can spend about 5 more minutes to explore cerner. Any questions?
Raj also put into the chat that they already have their own template for documentation. Raj, yeah, and thank you for that. I know that last time when we met, we talked about getting the nursing template from you, so which is what Mary is showing here. And what we heard is that the social worker and the dietitian documentation templates are still under review at the moment. So once we have all the templates that has been kind of finalized from your clinic's point of view, then we'll get those from you as well. And then we will be able to kind of build your own template here. So I think what we're trying to also accomplish here today is to see if you guys wanted to continue having your own template for documentation for nursing and also for the ally folks as well, and or do you wanted to kind of utilize what we have already developed enterprise-wide for template and also the power form and the iView for documentation?
I think we would probably need a little bit of time to look over those documents that you have in Cerner. Would you be able to send us copies?
No, absolutely. Yeah, we can definitely send you some screenshots. And I was also hoping to maybe have another session just with you and maybe the social worker and dietitians, just to review more in detail some of these notes. Once we have gotten those templates from you, we can definitely try to do some temporary build in our system or demo build in our system for you to kind of see what the future state will look like and see whether you guys like what we call auto text template or is what we have in Cerner in the iView and Power Form would be sufficient for your use for your clinic.
That would be great. I see that Bean put a question in the chat box as well about sharing them with her as well. So Bean is currently looking over some of our forms for our mental health clinician. I'm wondering, do you have a deadline or do you have a time frame that we need to get these forms back to you?
So for our clinic build right now, we are aiming for our validation by October. I believe our last date is like October 20th. So that's our validation deadline for your clinic. So hopefully we have kind of developed like, you know, the process and all the build that is required for your clinic by then. And then, and I don't know if anyone on the call here knows when is our build deadline for Richmond.
So I guess I'm assuming that I would need to get the forms to you well in advance of that bill deadline. So can you give me a time frame for when we need to get the forms to you? Because once they go through professional practice, they still have to go through BCH printing services. So I just want to get a time frame so we can pass that on to professional practice.
So if we're aiming for validation in October, we're hoping if we can get something from you by mid-September. Is that a reasonable timeline for you?
That should be fun. Thanks, Hilda.
Okay, sounds good.
And sorry, I'm not sure if that was Bean that just spoke up, but I'm not sure what the time frame for printing services would be. So maybe I'll reach out to them, because once we hear back from professional practice, we then still have to submit them and get, I think we were told we need were you telling us, Mary, that we would need a BCH number for each of the forms?
Right, I believe that's when they go through print service, then each form has their individualized ID.
Does anyone here
for
know
sure.
what that time frame looks like?
If not,
I think for us, for our purposes, as long as it's like it's went through like, you know, all the proper channels for approval within your site, and it has been approved by professional practice, that it's ready for in use, and then the process for that to upload into the print shop, I think that could be just more internally, and we should be able to kind of like mimic and use that information for our proposed bill for your clinic, even before the print shop approval.
Perfect, thank you.
No problem.
Yeah, so this is just one example of the template I received from Uraj. This is the RN pre-op medical history fillable template, which I just converted into Cerner, trying to mirror the ticky box or the drop down as close as I can. There are some things that can be changed into a drop downs for easy, quick, and for a quick response. So those can be updated or modified by the end user if it's created in-house. And then we would sign and submit by pressing this button. So things here like it says patient name, we don't need the patient name on the form itself because it's already attached to the chart. We don't need a line for the designation or name because it automatically gets stamped when the end user signs it. We'll just categorize the note type, position, okay, title, and we can call it RN pre-op. Pre-op medical history. Automatically stamp dated, and that's the author, so that's my name. Click sign. And we hit refresh. So anyone signs on would be able to see there was a pre-op medical history done on July 20th at 9:07 by username test user. And the information will be displayed like this. Raj, do you have any questions about this this template here or this auto text?
Sorry, that looks good to me. Thank you.
Okay. Yeah, and we can show you how to create it yourself. So it's earlier you mentioned what's the timeline. It may not be a huge issue. Not that we don't want to help the clinic, but I just want to show you, you do have the autonomy to create this. And it's just a matter of trying it a couple of times to get yourself familiar with the form. And it does use a lot of similar function as Microsoft Word, so you can copy and paste, transfer the actual Word document and paste it to this form or paste it to Cerner. So it's very user friendly. All right. We are now at 9:14, just doing a time check. Oh, just want to see, is there something we need to address in the chat? Oh, see if Hilda did that. Okay. Just want to get a feel of what our presentation would be like. So we done kind of the workflow ironing. We showed you what Cerner looks like through an external referral. So something coming, a referral coming from the community, going from the clerk, going through the accepting the referral, going through the patient's information, documentation, and then going through other forms. Now we want to talk about forms that we have from this clinic on a very high level. But actually, before I do that, and maybe Gabby can just take a moment to prepare, I want to reach out to our Ally Health friends here. Anyone from the clinic, from Ally Health, have any questions about Cerner or in terms of how you access, anything that you want to address right now?
Mary, can you pull up to the next slide? I believe Mushin earlier in the beginning of the meeting, she did mention in regards to like how the follow-up or referral to specialists will look like for their clinic in the future, knowing that there's a lot of specialists that the clinic does refer patients to. So I just wanted to kind of point that out. So for clinicians that are using Cerner or clinics that are using Cerner, we have these like referral orders. So for instance, if you need to refer your patient to another Richmond clinic, for instance, the diabetic education clinic or the Richmond IB clinic for that purposes, you can place what we call a referral order to those clinics. And those clinics will then follow the same process as what we have demoed earlier. Get your order in their request queue, and then the clerk will then go through either triage if the clinic does triaging, and then once the triage is done and they accept the referral, and then the clerk can put forward and book the patient for the appointment. And for clinics or specialists that are not using Cerner, those will follow current state. So however you are currently referring your patients to, for instance, whether it's going to be a fax referral to the referring provider, like for instance, like, knowing that like Dr. Harris, who has his own private office, and if you want the patient to be seen by him or at his office, you would then refer the same way that you currently do, whether it's going to be a fax or a phone call, the same way a communication. So there's no change because Dr. Harris and also the Dr. Sampath and Dr. Nguyen, they still have their private office, and those offices are not linked to Cerner. So placing an order in Cerner, they would not be able to get those. So you would just kind of follow current process of how you would refer those patients to these private specialists.
Sorry, Hilda, just for, sorry, I can't see the screen. What order is that? Although just for like tracking purposes, there is the referral to clinic not using CST Cerner order. So you're able to input that. So then it's on the patient's chart that that referral was sent.
Thank you, Mila. Yes, so there's also this order as what we call in Cerner is the referral to clinic not using CST Cerner, as we know that there are a lot of clinics that are currently not in Cerner. Those are mostly the private offices. So this order is what Mila was saying for tracking purposes. So if you put in the location, and also under special instructions. So you can kind of specify like whether this is going to be a referral to endocrinologist, to Dr. Harris, or to the surgeon and things like that. Once you have placed this order on the patient's chart, a paper requisition will get printed at your clinic. So from there, then your clerk can then use this as the requisition or the referral form to send out. And one of the benefit of using this order is, as Mila has mentioned earlier, is that anyone who have access in Cerner can see this and was like, oh, so this patient has already been referred to ENT, or has been referred to endocrinologist, has been referred to the bariatric surgeon. So they don't need to get out of the system and call your clinic to say, hey, has this patient been seen by respirologist? Like without going into like the documentation to see if there's a respirologist note or a surgery note and things like that. So just like easier tracking purposes, and also like, you know, for also looking into, for finding out information about the patient as well too. So this is like one way of referring to these outside private clinics and specialists as well. Any questions about this workflow? Dr. Harris, I know you just joined our meeting. Thank you so much for joining us. Yeah, so we have earlier had some discussion regarding the ordering piece for this clinic. I know that was a big topic within your group, knowing that current state, these patients will automatically get a list of blood work and diagnostics done. And then we have kind of like had a quite in-depth discussion about that. And then I think there's some takeaway within your group that you're going to review some of these options. And I think Dr. Sampath was saying that he also have another option that he was thinking of, but he will discuss with your team first before bringing it forward to our CST team.
Wait, and which was that option? What option was that, if you can paraphrase for me?
So some of the options that we have discussed earlier, the first one would be like, you know, having the provider placing the orders on these patients, whether it's going to be blood work or diagnostics, and knowing that current state that is going to be adding a lot of workload on the specific providers who are currently not really doing this work. So another option would be to explore the option of having nursing placing these orders. However, that requires some investigation from our end with professional practice, and also to see whether we need to kind of develop protocols and guidelines in order for these to be even a viable option. The third option we also discussed is to reach out to the referring provider, knowing that these are standard blood work and diagnostics that all these patients will be required to as part of the acceptance into the program. So that was also another option that was also being proposed as well too.
Third option is logistically terrible in British Columbia. That's a terrible idea. Third option is a terrible idea. Move on. What's the next option? No, it's a terrible idea. So many of the testing we order is restricted away from primary care. So your whole idea is just out the door right there. So what's the next option?
Yeah, no, thank you so much for letting us know
because we will receive so much complaints that you don't even know about with the third idea. You don't even know about the complaints that I already deflect in this program. Most of the micronutrients need to be they will look to see that a specialist ordered them. They will flag every non-specialist order on about 5 to 10 of the labs we do, and they will refuse them. They will charge the patient. They will fling it back to primary care and stop it. That's why our system's the way it is. So what's the fourth option that Dr. Sampath had proposed?
So sorry, just going back, Dr. Harris, to give you some context, that third option that Hilda mentioned was an option that Dr. Nguyen and Dr. Ahmed had suggested.
It's never going to work because they don't order the tests. So move on. Okay. Yep.
Yeah, no, thank you so much for providing some background
No,
information.
no, because you're right. Because you're right. The third option is how the entire province of Ontario does it, which is the best option. You're right that the third option is best, but vitamin D testing is not restricted in Ontario. Minimalistic nutrients like selenium, zinc, and copper are not restricted in Ontario. You've got so many provincial blockades in BC about this issue that are going to deter your option 3. That's my final comment. Okay. Yeah. Did Sampath have any other ideas?
Yes, Dr. Sampath said that he actually has another option that he actually came up with. So he did not share us with the option that he was thinking of,
okay.
But he said that he will share with your team first and see if he can get some consensus before bringing it to us.
I think overall for me, I'm less excited about this a month later. I've talked to Baljeet about it, the manager of this department, and we will pursue me being credentialed so I can order entry it myself as the provider. So we're just going to do that. The only thing about that option will be going live with your system for me to start doing that will be contingent on credentialing me. Okay, so that's actually the simplest fix.
Thank you so much for that. Yeah, no, that was definitely one of the things that we were also
the simplest fix. So I'll talk to Dr. Sampath about that. There's other issues with backups too. Like if we put it on, I think Dr. Chang's listening. If we put it on, like I tried to get Dr. Chang qualified, for example, for 2 years in Victoria on the vitamin D list so she could order it, and I still can't get her on that list. That's just an example of how they create barriers around this testing that is totally inefficient. And so the problem is one of our new team members is also general practitioner. It's going to be the same problem for that person, Dr. Cardeo there, Raj, if you're in Cardoso. It's going to be the same problem with her. And then even a general internist coming into the team and taking this on, it's basically asking a physician to join the team and do free work. So that's going to be a tough sell.
Absolutely. So yeah. So thank you so much for doing some work in the background, and then
I think we'll just have to credential me, and yes. Baljeet and I will have multiple talks about how we initiate that process and get it going, and Dr. Sampath as well. And I think by the sounds of it, go live is you guys anticipate October. In reality, that's going to be January, February, and I think that so. Ultimately, sorry to be skeptical. I've just worked in healthcare for 15 years, and I'm just being realistic. And ultimately, I think that I should be able to sort it out with Baljeet by then. So it should be good.
Okay, no, thank you. I think that that really helps with our discussion as well, but knowing that there are talks that you'll be getting your credential. And then, yeah, so we also said that, we'll work with the order set team to create those power plans for you for the blood work that you have sent over as well. So I think with those power plans developed, the ordering will be hopefully a lot easier, and then will be a lot smoother going forward. Okay, thank you.
All right. Thank you for that conversation. Excuse me. We do have some questions to ask the clinic, so I just want to take a moment to address them. So regarding to the check-in and registration process, what happens if the patient has a last-minute no-show? No, I see Dr. Harris smiling. I'm guessing that happens more frequent than we want.
Yeah, I don't know if you.
Yeah, so I mean, statistic wise, so it depends on which clinic you're talking about, but I would say realistically that we do have anywhere from as little as 5% to as much as 15% no shows on any given day in obesity bariatric clinic. So I think it's pretty common. Out of 30 people, that'll be 2 or 3 every day.
Okay, so in that case, let's say it's for your clinic and there's a no-show, then how do you communicate that back to the clinic, or how do we reschedule that for you? Or is there a referral you sent, or? Does the clinic send you another referral?
You're talking about my private office practice, or so I mean, for the most part, my private office practice outside of ECH. So I have my own private office rules. I don't, I do not charge no-show fee. I leave a message on the patient's voicemail that indicates for them to call me back in 8 to 10 weeks and rebook with my assistant a follow-up at that point. And I leave it open to them.
All right, thank you. And then
So
for the
Mary,
clinic,
yeah, we find out from Dr. Harris's clinic. Usually Dr. Harris will forward a letter to us saying that our patient no-showed for him. That's how we find out.
like an email.
Yeah.
Okay.
Just communicating over the notes. So when we all tell each other that has happened. Yeah.
Yeah, and for our no-shows, normally we do have it in the email confirmation that we send it to the patient. Like it has to be less than 20. If it is less than 24 hours, it is considered as an indiscretion, right? And which is marked in the chart for the patient. But if it is more than 24 hours, we try to reschedule it. But if it is a last minute call, no-show, we try to see if we can call some patient to come in, but it's zero chances that somebody will take that appointment because it's hard to get hold of any patient at last minute. So basically, we have no appointment then. And then we email the patient back that it was a no-show, or the provider, we always leave a message for the patient that you have been a no-show for my appointment. You need to call the front desk, that is me, in order to rebook it. And they also email the patient. And then when the patient calls, we rebook them for the next appointment then.
Okay. And Nav, I think I remember hearing something about there's like a number of no-shows, like a number of times that if they no-showed and they get discharged from the program.
Yeah, that are two indiscretions when they do it, then it is like, but it all depends upon the indiscretion. If it is some medical reason they have it, or if it is like a last minute, less than 24 hours. But we do two indiscretions and then they are discharged from the program. And it's that two indiscretions could be, I don't know, Raj can correct me if I'm wrong. It could be for anybody, any provider, anybody in our team, not just the dietitians or anybody, but most of everybody. It covers ultrasound, bone density, whatever we send them for.
Okay, so it's not just no-shows for your clinic. It's like all the specialists that have been referred to, and then
yeah. So it's service provider appointments is the main one. Now that's pretty hardcore. I wouldn't kick anyone out if they missed my labs or the bone density. I think that if they missed labs 10 times in a row, we have those serious conversations. But that's an only relative indication. It's really the service provider appointments missed where there's psychiatry, respirology, internal medicine, nurse, dietitian, social work, psych eval, behavior eval.
That's correct.
Yeah, I mean, if you're in the psychological course and you're in the change ways course and you missed half the appointments and there was like 6 or 7 of them, I think that's going to be counted as the service missed too. So is it? Do you count that one, Raj?
No, we don't
count
count
that
it.
course.
We don't count it because it's not mandatory, but you're right, Dr. Harris. It's all the
But it's arguable
providers.
they missed the whole thing. It would be a strike, probably, right? Yeah.
And that is being documented in the patient's chart. And then you guys will be able to follow that. So is that in the patient's chart, or is that NAV like have a book to
It's in the patient's chart. So each of the patients in their chart, we just have sort of a orange form that we've made up. It's the very first thing that we see in the patient's chart. And if there is an indiscretion, it's explained the date, who the indiscretion was with, which appointment they missed, why they missed the appointment. Yeah.
Okay.
So I guess that's something we would be building into Cerner as well.
Yeah. Yes, I don't think we captured that previously. So
that's right.
So Raj, if you don't mind just sending us that form as well, so we can take a look to see how we can capture that data, because it is very important, knowing that you guys have multiple service providers in this program, and if that's considered, something that will kick the patient out from the program for tracking purposes.
Yep, I'll forward that.
Okay, thank you.
Can you tell us more about the check-in process for the orientation? So my understanding is there are roughly about 50 people that would show up in this virtual meeting.
They don't actually get checked in. I'll let Nav talk a little bit more to that, but The orientation really is just an email mass send out with a Zoom link for the invite. And then patients have to reply within 2 weeks of attending that virtual orientation if they're choosing to opt into our program. And if they are choosing to opt in, NAV would then register them into PCIS. So it's not an actual check-in per se for orientation, but NAV, correct me if I'm wrong.
Yeah, no, you're right. That's how because we put them in ORMER, so we know actually how many patients have come for the orientation, because each patient that confirms that they will attend the orientation are entered and registered in ORMER. So we have the total number of patients there. Now they attend the orientation, as Raj said, within 2 weeks, they have to let us know that they want to opt into the program. Once they opt into the program, I send them the forms, blood work, requisitions, all that is needed. And the patients who do not opt into the program, I try to call them once just as to see, because it could be various reasons that they couldn't attend it, and we give them another option, second chance. If they want to attend the follow-up appointment orientation that we are going to come, and sometimes they say no, they don't want to after listening to everything or what it is, they don't want to opt in. So then we send those referrals back to their referring physicians via fax.
Right.
So that way they are discharged, like they are out from the program, and we write the reason, what the reason was, like if they attended or they opted out. So we give those reasons and we fax it back to them. And once the people who have opted into the program and we have sent them the forms, when I receive the forms from them, then they become our patients, and I put them in PCIS and I register them and they start their journey.
Great, very comprehensive. Now, so that it leads to our fourth questions. So when you say you try to call them once, you don't get hold of them, and then you try again later, does those action gets tracked on that orange sheet we mentioned earlier, or do you document that in ORMES?
No, they don't get tracked in orange sheet, because that is made when the chart is made once they come in PCIS. So at this moment, I cannot confirm it if they all are tracked, but normally on their referral, we do write it down that they attended first or they didn't attend it. Now it's the second one they are going, so we write the second date. It's all handwritten on their referral. That's the only way we have them there.
Okay. And this is like how you're currently quote unquote tracking for these orientation attendance in that sense. On the referral form with the date of the orientation.
Yes, so yeah, that's how we do it. And then when we book them in PCIS, like that's the orientation date. Normally, their face sheet will have the orientation date that they attended it. So when nurses are doing the medical history or anybody, they exactly knows like when this patient came, because we try to put the orientation date on their face sheet.
And I guess moving forward, is there any appetite of moving this process over to Cerner? Nav earlier of how I've kind of demo, for the clerk of booking the appointment. So you'll be very similar booking orientation appointments. And once the Zoom orientation actually happened, then you kind of do the check-in process to say, yes, the patient attended the orientation. And then I know from our previous conversation, the only reason those appointments are being tracked in ORMES is for the tracking purposes. Yeah. So in Cerner, if those appointments are being booked and checked in or not checked in or not confirmed in that sense, we also have a way of tracking and pulling those reports for you. So I think moving forward, is this something that the clinic wanted to move away from ORMES and pull that information over to Cerner?
Yes, that would be great actually, if we can track it, because right now, all I'm tracking is doing manual tracking. That's all I'm doing it. So it will be great, because normally even the people who attend the orientation, I go through the Zoom and I print a report which tells me how many patients out of 50, 35 patients attended the orientation. I have to get the report from Zoom, and then I come to know, and then I have to separate those referrals, whoever attended and whoever didn't attend it. So the patients who didn't attend the orientation, I just call them to find out what was the reason why they didn't attend that. And if they want a second chance to come for the next upcoming orientation, then I book them for another one.
Okay.
That's all manual tracking I'm doing right now.
Yes, yes.
Sorry, just sorry to interrupt, Hilda, but just going back to that, I know we had talked about that at a previous meeting, but I'll take that back to management because that's right. The only reason we're using ORMIS right now is just to track numbers for the Ministry of Health. And if all of that tracking will be done through Cerner, then yeah, we wouldn't need it, but I'll just I'll confirm that with management.
Okay, perfect. Yeah, no, thank you, Raj. I think there are some kind of requirements from ORMIS for tracking for the surgery program. So if that's something that you guys do need to kind of track in ORMIS, then we will kind of leave that out of system, meaning that it's outside of Cerner. And then in that case, then those will be current state.
Yeah, so just to be clear, we don't want it to be that way. We would prefer it to be through Cerner, but we just have to. I don't have the authority to tell you that, so I'll get back to you. Yeah.
Okay, no problem. Thank you for checking on that.
Raj, question with ORMIS and what do you report to the Ministry of Health exactly?
So actually, it's one of the admin support team with Bell that tracks all the information. We input it all into ORMIS and they then access it and forward it on to the ministry. So I'm not sure who they liaise with.
Would we be able to get a copy of that report?
You would have to check that with the admin. That's not us. So we just put it into ORMIS. We don't retrieve any of the reports.
Okay. Is there a name you can?
Yeah, it's Mary Escobar.
Oh, okay, sure.
Yeah.
Thank you. Is it a monthly report that they do? They set up?
Again, we only input data. They retrieve it. I don't know how often they're retrieving or how often they're sending that information.
Okay. Thank you. All right. So we need to move backwards a little bit before I can move forward in the patient journey. I believe there's still some outstanding questions in the screening and triage. Okay. So just to recap, there's the internal where you're sending referral from a Cerner to another Cerner site. External referrals when you're sending from a non-Cerner site to a Cerner site or vice versa. Okay. The provider can either can enter a accept or reject referral, which goes to a queue with the clerk so they can action upon that. All right. In terms of screening and triage, we want to know if the private MOA wants to have read access to Cerner. And I think Dr. Harris, another provider here that wants to chime in.
Can you repeat the question, please?
Do you want to grant access to your private MOA, read access to Cerner?
I guess the question is really any of the specialist's office, does your MOA need access, like reading into the patient's chart? And then
no.
Because the providers, you will have access to Cerner.
Yeah, I understand. This whole process is actually doubling all the data for me. So no, we're good. We've already got all the data in my private system at the same time. Because we're going to set it up that it's going to be ordered out of the portal for the RMBS and pull the data back in. But we're going to have to CC Dr. Harris and Dr. Nguyen on everything anyways. So I'm already going to get it. The short answer is no, we're good.
Okay, thank you.
Just curious. Dr. Harris, do you use SOS as well?
Yeah, I don't use it. I have access to it. I don't use it regularly because I use Plexia. So I've already paid for Plexia for 15 years. So I use Plexia.
Do you happen to know what other system SOS is integrated with?
None.
So it works in silo at the moment.
Yeah.
Okay, thank you.
It's a siloed system. Yeah. I use Acuro, Plexia, SOS, Sunrise, and what's the other one? Epic from Ottawa. So I use 5 different EMRs or 6 or something.
Earlier we mentioned about some of the referral needs to be expedited. Is there an algorithm that determines if these are urgent, or it's dependent on the source of the referral?
Yeah, it's dependent on the source. So we have sort of a collaboration with some of these medical weight management programs, and it's only the recognized ones that we have met with and collaborated with that So we would just recognize the referring clinic.
Perfect. Thank you for that clarification. Okay.
Sorry, I just want to go back to that previous question. You mentioned that it's dependent on whoever sends that referral. So if it comes from a certain program, are all the patients from that program considered urgent, or is that indicated otherwise? Yes.
They indicate with the words expedite right on the front. Yeah.
Thank you.
There is basically a list of service providers that if you can formulate a list that they're all expedited. So everyone at the Medway Clinic, there's about 8 of them. Every member of our team, like Dr. Ahmed, Dr. Harris, Dr. Chang, the surgeons will all have sort of expedite capability or privileges in our program in the past. And there's reasons that historically got set up. That's a long story, but Dr. Zentner, her whole team, the Revolution Clinic, that whole team, and those are the main ones right now. There is some peripheral clinics, but I think they're ad hoc, right, Raj? Like if you get a Dr. Klur, you get a Dr. Vala, or if you get a Dr. Aspire Clinic, Langley, you guys are sort of like, you're not necessarily expediting those, right? You're still bringing, what's the process with like Aspire Clinic right now, Raj, for example?
We are expediting them. So
okay, so they're
I'm
on the list too. They're on the list too.
I'm putting them into the chat box, but yeah.
Oh,
you're
thanks,
right.
Raj.
Yeah.
Thank you so much.
Yeah, and when I was demoing the clerk workflow earlier, I think I showed a field that has like the triaging priority as well. So that's also where the clerk will be able to kind of like, knowing that you guys have a developed process for certain providers, certain clinic referrals, those will be expedited. So so you can assign a certain like number for the priority, then that way it'll be easier for the triaging of the these requests as well too. So so there are ways for us, as long as you guys already have a developed process. So whether it's going to be A, B, C, D, E, F, G, or 1, 2, 3, 4, 5, 6 as the urgency for these referrals. So so that's something that within the clinic you guys can make that decision and make those changes. Raj, I do have one quick question. Who does the triaging of these referrals current state?
They're actually not really being triaged. So the med weight referrals are expedited. I do look at all of those. And other than those, the rest of them that come in from primary care, they just sit on a wait list for 2.5 years.
So there's nobody triaging them. They're just on the wait list automatically.
That's right.
And then what if those are inappropriate referrals? Would you still?
Oh, sorry. Yeah, so I take that back. You're exactly right. That's a good point. That's a good point. So some of the very basic criteria that the surgeons have asked for is the patient's weight, height, and BMI. Mm-hmm. So that is definitely one thing, along with age, that the MOAs at the surgeon's office will look at. And so if it's in an inappropriate referral, they will fax it back to the referring physician. And the only other exception is sometimes if it's an urgent referral, say I gave that example of a patient needing a kidney transplant. So that in that case, sometimes the referring physician will actually reach out via phone or email or fax to one of the surgeons on the team, mm-hmm. and we'll pull that requisition. So that's something that would then be triaged. But other than that, yeah, the rest of them just sit on the 2.5 year wait list.
Okay. So just going forward, knowing that we have proposed, I think the last time when we talked, that all future referrals will be coming directly into your clinic and won't be going to the surgeon's office. So who will be taking on to that role that the private MOAs are, quote unquote, redirecting or returning those referrals back to the referring provider?
That's a great question. I'm wondering, is there any way, if we're building that, if we end up building that into Cerner, I know Dr. Nguyen and Dr. Harris already did some work on having some sort of an algorithm, like certain referrals that come in, there would be prompts, right? So if the referring physician says like, oh, this patient's BMI is below this, or this patient has active neurocognitive disorders or has had active suicidality in the last 18 months, they would not be appropriate. So would those then get weeded out automatically? I'm wondering if that's something we can maybe build in.
Yeah, unfortunately, because it's a paper fax, those data are not entered as a field in Cerner, right? So the system cannot kind of pull those data to say that, oh, this is the weight for this patient, this is the height of this patient, right? It's just on a paper fax. So it does require manual, like somebody needs to look at that referral to say, okay, so these are what the set of criteria for this patient, and then they don't meet the criteria. And then now the next step would be to kind of like, go back to the referring provider, rejecting the referral, right? We can definitely build what we call earlier, like those like auto text templates to say like, hey, Dr. Who and Who, based on like A, B, C, D, E, F, G, you can just check mark which one that they don't meet the criteria. And that's why we cannot accept your patient into your program, right? So that could be auto text as a template to build for you. However, that triaging or that screening process, it has to be a manual process as current state that private MOAs are doing. So I guess within your clinic, you can decide whether this is going to be like NAV doing it, or if it's somebody else will be responsible for taking that role as well.
Well, can that be a take back? Can your team look at that and decide? Because one way or another, we're going to have to change our current state anyways. Like right now, faxes are coming directly to the surgeon. So we're going to have to change the system by making adjustments on pathways and making adjustments on our website.
Correct.
If that's what we're going to do, could we not put a link in on pathways and on the BCH website that links them directly to a system that will go to Cerner so that they could fill this out online rather than sending a paper requisition?
Unfortunately, a lot of your referrals from what I heard are coming from the GP's office. They're not, so then those are what we call external referrals. So, so a lot of the GP or community providers, they don't have Cerner access. So if the only internal referrals, we might be able to kind of like have that feel or that documentation, but then for external referrals, unfortunately, will be paper fax. So that will be
so if they, yeah, I think what I mean is if there was some sort of a link and that link took them to a form that they could fill out once it gets submitted, could it then somehow feed through Cerner or still not?
No, unfortunately, that's not an option.
Yeah.
So I think this needs to be something the clinic right now. I know you guys are kind of like working through the referral process of like streamlining that all into the clinic instead of going to the surgeon's office. And I think this is something that within your team, you can also discuss to say, if these inappropriate referrals, how are you guys going to be managing that even before Cerner comes live, right? And then from there, we can kind of like mimic the same process going live with Cerner.
And just going back to your point earlier, Raj, currently there's just not a functionality within Cerner to transpose what is received through the workflow monitor as a PDF over to the fields that are within Cerner. There's no mapping, the more technical term. So that's why we can't just transfer the information from a PDF document and map it to the field that you would see in Cerner. That helps. Okay. I'm gonna go back and make sure I leave no rocks uncovered. So receiving referrals. Slide 22. Okay. Urgent referrals. We talked about that. Let me see. Are there any other types of document included with the referral forms? Such as lab or diagnostics, and who ordered them. So we kind of briefly brushed over that earlier when we talked about ordering blood work. Is there anything that we need to expand on this? And in terms of how do you manage the internal external referrals? So my understanding now is that most of the community referrals do go to the private clinic themselves. And then for any urgent referral that's been established with the clinic, they go directly to the clinic. And we take a look at the website and it looks like there are a few private, or there's few providers named listed on the website. So how does the provider know who to refer, which provider to refer the patient to?
So typically when we're getting referrals, they're just referring them generically for bariatric surgery. They don't always put a surgeon's name on there. Just knowing that we have 3 bariatric surgeons, and the understanding in our clinic is that we're referring the patients once they're cleared by Allied Health and the specialists to the first available surgeon.
Anyone from my team has further questions to ask about that process? Just want to double check what system is used to communicate incomplete referral and who is it done by? So if they're missing pages or missing questions on the referral package, is it?
Something that, yeah, so typically we don't see that until their name has come up on the wait list. So it'll be about 2.5 years later. And then it would be one of our unit clerks that would flag any missing information. We have a template made up. We can also share that template with you. And the template basically says, thank you for your referral. This is what we need to complete this and invite your patient for orientation. So please send the missing information, essentially.
I think it's important to say that the MOAs of the surgeons, when they receive the initial fax, let's say they were referred a BMI of 29 with diabetes, they will immediately reject it at the point of contact. So there is, that's occurred often. I know because I've had it done to me, where Kathleen rejected me. and so she's a wall, right? And so they send it back right away, but then when it's accepted with the criteria, then it sits there for 2 years and then comes to Raj and Navneet and Tasha and everyone else. So there is that initial step of initial like outright rejection. Yeah. Dr. Nguyen and I have started to preliminarily work on a portal for British Columbia that could be a web-based portal where everyone could just go to a website to do referrals. And we based that on the Ontario Bariatric Network. So that's what Raj was referring to. We've programmed a portal entry data point where you run through those 10 to 15 questions and you're immediately ejected if you have unstable depression or whatever. So we're going to basically protocolize what the MOAs and the surgeon's offices are generally doing. And then when that comes in, that'll let's say print off or sit there, and then that would get transferred over to the team and everything.
So that'll be great. Yeah.
Dr. Harris, for
that'll just be another step that's outside of the Vancouver coastal sort of pathways of care.
Yes, and then when do you anticipate that website will be up and running?
2.5 years.
2.5 years. Okay. So
that's sort of like a realistic statement. I mean, we haven't worked, to be honest, I don't know why we haven't, but we haven't worked on it in 6 months, and you're making me feel like we need to get going again. Yeah. So I think that realistically, I think one of the problems is also is what we'd like to see in BC is a unified process where everyone comes through that portal and then is distributed geographically according to catchment area. And it's about us all getting along across the province for that kind of coming together to create that system, which unfortunately we're not at yet. And I think that's the reason I'm saying 2 years, is because of bureaucracy. Okay.
Definitely, no, totally understand. So I think that's definitely good to know. That's a good information. So knowing that, having that website, if all referrals will be kind of quote unquote screened through that website, and then that only the appropriate referrals will come through to your clinic, then there's no triaging process that's needed. Then just automatically goes to your wait list.
That's right.
So that's something we can keep in mind. Unfortunately, until that process is developed or the website is up, we do have to have some sort of internal screening process that might require somebody from the clinic to do that rejection prior to the being put on the wait list. So yeah, just looking at the time, being conscious of the time, we are 2 minutes to the end of our meeting. Mary, I think we still have a few things that we do wanted to go through with the clinic. So I can foresee that we do need another session with the clinicians, knowing that there are still quite a few outstanding questions and decisions that is needed. So we are proposing for the week of the 11th, knowing that Raji will be back from vacation by then.
I'm away the month of August. I'm away from July 31st to September 5th.
Okay, perfect. So we're hoping to kind of maybe book another session on the week of the September 11th.
Oh yeah, that works.
Yeah, is this something that you want to take away with your team, with all the providers?
Sure. Yeah.
Okay, so we're hoping for hopefully another 3 hours if possible, knowing that I know it's difficult to have like, you know, a 3-hour session. So if there are available times, like even an hour with the providers, we can just like power through those outstanding questions with the providers. And then with like the remaining time, we can definitely kind of go through some of our clinic workflow and clinic questions. And then maybe kind of proceed like of what we did earlier.
Yeah, I mean, I can definitely say right now that 3 hours is probably not going to work for most of the docs. And then I know today was a one-off because it was our first time meeting a lot of your team and your team meeting our team. So we spent a lot of time with introductions, etc. But I would just ask that for the next meeting, then if we can just focus on what we need from the physician so that we can get them on their merry way, that would be great.
Perfect. Yeah, we'll definitely do that for our next meeting. And then, so yeah, even we can get an hour or two with them, just to work out some of those outstanding workflow questions about regarding the ordering, and then continue with. I think we went through the demo quite well, so the clinicians have an understanding of what the workflow is. So we just have some outstanding questions, and maybe we'll review some of the forms. And if you have those dietitian and social worker forms have been validated, if you can send them our way, we will be able to kind of do some like demo build too.
Yes, on that note, I'm gonna have a quick meeting with Bean later today, and then I'll get back to you, Hilda. But I think Bean was asking whether I can just send everything to you as is, because you might be able to cross-reference it with what you have already. I think for us, I guess my understanding is that the content has actually never been looked at by professional practice. And so because we're also going through accreditation, we were told that it would have to be reviewed by professional practice anyway.
Yeah.
So I'm not sure if you want those forms now or after they've been reviewed. That's what Bean was asking.
Preferably being reviewed and having given the approval from professional practice. That would be better for us to kind of move forward with the bill.
That was my understanding too.
Okay, awesome. And then I guess from our next session, then we will have a validation session, which, like I mentioned before, which is sometime in October. So we don't have to set out on a date on that one yet. Maybe we just kind of focus on the week of the September 11th session, and then we can confirm the date later on for the validation. Any other questions from the clinic side or from the CST side? Okay, awesome.
I guess I have one last question. Sorry to keep bringing this up, but
no, that's okay.
The whole question about whether we can get Dr. Harris privileged, then we're going to look into it on our end. But if you find out anything on your end, it would be valuable if we knew all of that prior to our next meeting.
Yes, this is Johanna. So we already brought this up, Dr. Harrison, to Dr. Grafstein, who is our Chief Medical Information Officer, and he's talking with Nancy Austin and also with Aleko, and we're working to get you all that done. So we will get back to you. So we're working on that. Thank you.
That's good. Now I know Nancy and Alec very well. Oh, so yeah. I'll talk to them. I'll talk to them about it too if I have to. Yeah, that's
excellent. Okay. Thank you.
Yeah, thank you, Joanna.
Okay, perfect. So I think there's some work in the background, and thank you everyone for all your hard work. And hopefully in our next session, we'll be able to bring forward some of the options and be able to kind of come to a consensus as well. All right, in the meantime, please feel free to reach out to any of our team members, me, Mary, or Gabby, if you have any questions. And yeah, we'll look forward to hearing from you, Raj, regarding our date for our next session.
So thank you.
All right.
Thanks everybody for your time.
Thank you.
Bye.